लाइव हो गया.
So we are live now.
Yeah.
So we are live and we are about to start. A very good afternoon to all the dignitaries and respected guests. We are very glad to present this webinar on fetomaternal surveillance in association with Vidarbha ISOPARB Deoli Sawangi Obstetrics and Gynae Society, along with Obstetrics and Gynae Societies of Bhagalpur, Darbhanga, Katihar, Magadh, Muzaffarpur, Patna, Saharsa, Sitamarhi, Dhanbad, Bokaro, and Jamshedpur. The convener of this webinar is Dr. Surekha Tade. Dr. Surekha Tade is Professor and Unit in Charge at JNMC, Wardha, Sawangi. So let us go to Ma Saraswati and seek her blessings. Before starting the webinar, I request all of you to kindly join for the online inauguration of this webinar. Nisha. I request our convener, Dr. Surekha Tade, to kindly introduce our chief guest and guest of honor to the house.
Thank you, Dr. Rashmi. Live as if you would die tomorrow and learn as if you will live forever. This is what Mahatma Gandhi ji has taught us. And I am from Sawangi as well as have been in Sevagram for last 20 years and Mahatma Gandhi Institute of Medical Sciences, which was actually the place where Mahatma Gandhi stayed for 12 years. ISOPARB Vidarbha chapter and Deoli Sawangi Society is very happy to collaborate with all the societies of Bihar and Jharkhand today for this webinar on fetomaternal surveillance. We are really honored to be collaborating with Bhagalpur, Darbhanga, Katihar, Magadh, Muzaffarpur, Patna, Saharsa, Sitamarhi, Dhanbad, Bokaro, and Jamshedpur. And it is our great pleasure and honor to welcome all the faculties today. Special welcome to our chief guest, Dr. Mandakini Meg ma'am, our guest of honors, Dr. M.G. Hiremat sir, Dr. Yashodhara Pradeep ma'am, namaste, Dr. Professor Kalyani Singh ma'am, welcome ma'am. Our very scholarly person from Vidarbha, Dr. Lakshmi Shrikhande madam. She is our esteemed faculty today, guest speaker, and also Dr. Mitra Saxena madam. These are our two very important and very scholarly guest speakers. We have chairpersons, Dr. Vinita Singh ma'am, Dr. Bharat Prasad sir, Dr. Ranjana Joshi. We have Dr. Leela Vyas, then Dr. Pratibha Rai and Dr. Maya Shankar Thakur as our chairpersons. Welcome to the chairpersons. Then we have a case-based discussions on CTG from traces to cases where we have two experts, Dr. Anjali Jha and Dr. Supriya Jaiswal, and our esteemed panelists are Dr. Kavita Banwal, Dr. Shweta Kumari, Dr. Shashi, Dr. Sadhna Sinha, Dr. Samita Thakur, Dr. Lata Gupta, and Dr. Apurva Datta. So we extend a warm welcome to our esteemed faculty and our participants for this important webinar on fetomaternal surveillance. I would like to inform the august audience that we have been doing these academic activities under the guidance of our patron of Vidarbha chapter, that is Dr. Lakshmi Shrikhande, and we have been traveling and touring throughout the nation, and we have been conducting these academic activities. We recently did academic activities in Kerala, Tamil Nadu, we did 2, Karnataka, then Andhra Pradesh, Telangana, West Bengal, Northeast, then we did in Haryana, Punjab, Uttar Pradesh. So almost we have done 20-25 webinars recently in the last 3 to 4 months, and we have been connecting to learn ourselves from all of you. So thank you very much for joining us. And I would like to introduce our chief guest to the august audience. Can I have the slide of Mandakini ma'am? Mandakini ma'am actually does not need any introduction. We all know her illustrious career as the... can we mute the other people, Nisha? So Mandakini ma'am, we have seen her illustrious tenure as the chairperson of the ICOG in 2020-21. And before that also, madam has been so much active in FOXI and ICOG. She has been the Vice President, International Vice President of MWIA Central Asia, Vice President of, again, the Central Council of MWI, the National Vice President of FOXI in 2012-13. And of course, she has been with the Indian Federation of Ultrasound. She has also been the past Dean of Indian College of Medical Ultrasound, and various other posts she has served, especially in the public health services and family welfare in the government of Maharashtra, and also the prestigious post of Superintendent of Kama Al-Bless Hospital. So you can see that madam has so many awards, she has headed so many posts, but the most important thing of madam is how she has been connecting and guiding all the youngsters to come up and to be, we have seen that recently more than 250 fellowships in ICOGs were awarded under her leadership and guidance. Madam, we are blessed to have you as the guest today and our mentor. We are really honored and we await your pearls of wisdom.
Surekha, thank you very much for that wonderful and very warm, very personal introduction. Good evening to everyone. And I'm so delighted to be here again with my friends after a mega meeting in AICOG Indore. 1 minute, just a minute. So, first of all, I would like to congratulate Surekha, being so gentle, so, humble, and at the same time, taking the academics to each and every corner of the India, connecting with everyone under the patronship and the leadership of my dear friend, Dr. Lakshmi Srikhande, who is soon going to be in my shoes of the ICOG chair. And I'm 100% sure that she is going to do a great, flying of whatever I left from where she's going to take it to a greater heights. I'm 100% sure. So with this enthusiasm, zeal, and all these things, Surekha and all ISOPARB, Deoli, Sawangi, OBGY society are taking really academics very, very seriously. And we are extremely happy that how you connect to the so much, important, excellent and experienced faculty all the time. Whenever I read your flyer, I can see Mitra, I can see Yashodhara, I can see, everybody in the field, so many from my Patna, Vinita. I am really, I will take some tips from you. So thank you very much for all this honor. Most of all, I'd like to welcome, a warm welcome to my co-guest, Yashodhara, a very, very dear friend. हम लोग काफी साथ में घूमते हैं बाहर भी और उनके हस्बैंड से मेरी स्पेशली दोस्ती है ना. यू डोंट माइंड, आई होप यू डोंट माइंड. सो I was the president of IFMB, and after me, he became the president of IFMB. We got a very strong family-like bonding. So Yashodhara, thank you very much. Second is Dr. Hiremat. I know him so well. He was the past chairperson of ICOG. Welcome, Dr. Hiremat, and also Dr. Kalpana Singh. Welcome. And all the dignitaries, I can see faculties, excellent faculties here. Anisha, Lakshmi is of course there, and all the faculty, Apurva, all my juniors, seniors, Supriya, chairperson. And the topic, I think, Surekha, you have done, kept very well. When we are, celebrating our maternal mortality rate has come down so well in Maharashtra, say 38, and also this 20 in the Kerala, but still, there is so much to be done. We can see our Safe Motherhood Committee chairperson, doing so much for the PPH and things like that. But the feto-maternal surveillance and CTG topic which you have kept is going to give a lot of inputs for the well-being of the fetus, for the maternal. I remember, I think Lakshmi and Mitra will remember, एक छोटा सा फिटोस्कोप लेके जल्दी से हम लोग छोटे छोटे थे अमरावती विमेन हॉस्पिटल में जाके फिटोस्कोप. That was so primitive, and sometimes we used to feel अरे यार कहीं fetal heart बीच में बंद हो गए तो सुपरिटेंडेंट हमको कितना डांटेंगे, and you know it was quite a primitive. From that on, we have come to this CTG level. We have come to the computerized tomography and all this, and you can just see everything in the hand, and you can make a proper decision and intervene whenever required. It's such a smooth thing to do and very simple also. So I think I won't talk much about the subject. We have experts here. So I welcome all the excellent faculties here to do the justice to their subject, and the delegates will be so much benefited. And once again, I wish Surekha all the best. I'm 100% sure, I don't have any doubt about it, that you will be very successful, and we will be again on the screen celebrating and rejoicing. So thank you very much for this honor. Thank you.
Thank you. Thank you very much, madam. We are always blessed by your support and blessings, which you always shower on all of us, and you hold our hands and take us to wherever we are. It is because of your support. So with that, I would now would like to welcome our guest of honor, Professor Dr. M.G. Hiremed, sir, who is the principal of KLE JGMM Medical College, Hubli, former director of Karnataka Institute of Medical Sciences, Hubli, director of HIVF Center, Matushri Women's Hospital, chief patron and founder of Kasoga, past president of HDOGS and Kasoga, ex-chairman of press committee of FOXY, has been the vice president of FOXY in 2017, and recipient of the Millennium Fellow Award for Excellence in Academics by FOXY in 2000. And must say that Dr. Hiremed, sir, has been instrumental in taking academics to greater heights, not only in Karnataka, but all over India. And we all know that now the academic wing of Kasoga has started, and he is there at the helm of affairs, and more than 200 webinars, he said, he has conducted. And that is how, you know, he's been at really pioneering the work through now the digital platform, before that the physical platform, and we all are benefited, his students. And Professor Hiremed, sir, we are really honored to have you here today, and welcome, and please guide us on this forum and be with us always. Sir, you are on mute. Please unmute yourself.
Can you hear me?
Yes, yes.
Good evening, namaste to everybody. It's a great honor that you have invited me as a guest of honor, and I am representing 3,000 members of Karnataka State OBGY Association and our KCOG as a chief patron. And I am really delighted, and I have come in contact with Dr. Madam in the last 2-3 conference. Today, there are twin academicians. One is Dr. Surekha, another is Dr. Rashmi. Both have done a wonderful work by inviting so many great experts in the field and so many foxy Dians. And really, it's a pleasure that you have done such a wonderful work. And as rightly told by our chief guest, you have selected such a wonderful topic today, fetomaternal surveillance. I think that is the day of the order, where we want to give the one of best the child to the mother, and happy and healthy mother to the whole community. I think you have selected a wonderful program, and you have selected such great speakers here. They are all the experts in the field. They are going to do, and in fact, inverting the pyramid of antenatal care is the real thing what is needed today. That we have to invert this and see that the maternal mortality, morbidity, everything comes down. Not only that, CTG also you are going to discuss in such a length, basics to the case discussion. I think delegates will be definitely very much pleased with your program. I am very, very thankful to you having invited me as a guest of honor, and I think you are given respect to whole of South India. I am representing whole of South India in the dance of the North Indian, the experts. And I wish all the best for this program. Thank you very much. And I give an invitation to all the Dians here who are here. Please come to our Karnataka College of Obstetrician programs, which are happening on every Thursday at 7:30. Sometime I will invite you. Please do come and address. And this is the way that we have to do. Elders should give their knowledge to the youngsters, and that is how the academics will continue to go. And this effort is not a small effort. I know I have organized more than 100 in the last year. How difficult to organize a webinar, how difficult to convince a speaker. And you can bring the greatest of the great speaker, but it is so difficult to bring a delegate to listen, because what I always think is my job is to take the horse to the water. It is left to the horse to drink or not to drink. I think that is the message I want to give to delegates. Please see that how much efforts the people who are arranging the academics. Just spend your few half an hour, 1 hour, 2 hour program. Spare some program for academics. Definitely, we need to update our knowledge. Once our knowledge is good, we are caring our patients. We are really doing the job to the best of our ability. Thank you once again, Dr. Surekha, Dr. Rashmi. Nice to see Mandakini Madam as the chief guest, always smiling. So whole program will be smiling. Everybody will be happy with this program. Namaste. Namaste,
Thank
Madam.
you. Thank you so much. Thank you so much, sir.
Yeah.
There are two devices. Somebody is having two devices. Can all the devices be muted, please? Thank you very much, Hiremat sir. I think a very nice message has been given that we are integrating, all the states together are coming together, north with south, with everybody is so, happy with each other collaborating. So I think that's the message we are giving, and we are taking academics throughout India. So thank you very much. And we'd like to be associated with you again and again, sir. Thank you so much.
Thank you. Namaste, Madam.
And now it is my pleasure to introduce a person of great respect, not only in the North, but all over India. She is an institute in herself, we must say. The type of work she has done and the way she has guided again the youngsters to come up to a level where they themselves are now leaders. So none other than Dr. Yashodhara Pradeep ma'am, who is the Vice President-elect of FOXI in 2020-2023. And before that, the type of work she has done as a professor and head at she is presently at Ram Manohar Lohia Hospital, Lucknow, and as a senior professor in KGMU. Before that, she has been in ELMCH, Lucknow. And of course, we have seen her work in the Family Welfare Committee of FOXI and also in IMS. We have seen, I have been personally observing the type of work she has been doing to prevent cervical cancer. These are the work. And of course, presently, she is the president of Lucknow OBGY Society, also the Lucknow Menopause Society. Vice president, she has been in 2018, and so many awards as a Best Teacher Award in KGMU. I think that's a huge, wonderful honor, madam, in 2015. And of course, she's headed the urogynecology committee also and received various awards. Must say, madam, the type of organizations you have brought up and nurtured, ISOPARB, PCOS, LMS, ISPAT, IF, UMB. I mean, you are really an inspiration to all of us. Let us know how you managed to do all these organizations, how you managed to lead. So the dais is all yours, ma'am.
Thank you so much, Surekha. My throat is not very well, but still I'll try. So thank you so much for giving me the opportunity to join this program, and I was looking forward for this invitation, although I had some meetings, so I just said start at 5 because so I can go to other at 5:30. It's a hospital sort of a meeting. So it's my pleasure to be invited with the people who are with co-hosting, with sharing that dais with my friend Mandakini, who is such a great person. I know her through my husband also. So in that case, she is very, very close to me and senior to me. Both the things are there. We are really associated with her, and Mandakini has a great human being and a great person. There's no doubt about it. Dr. Hiramat, probably we have not met many times, but I have heard about you and I know you are doing a great job. So I'm so thankful that today I could meet you on this platform.
Thank you, madam. Thank you.
Thank you so much. I am so happy, Surekha, that you have invited me to when you are this Vidarbha, ISOPARB Vidarbha, and this Deoli Sawangi Society is organizing with Bihar and Jharkhand societies. Because when I was going for my Foxy Vice President election, and always the Bihar Jharkhand societies are very, very to me, and I'm really thankful to you.
We need to mute all the others. Nisha, Mandakini ma'am, can you mute yourself? Mandakini ma'am,
Yeah.
please mute
All
yourself.
Bihar. Yes.
Yes,
Thank you.
please go ahead.
All Bihar Jharkhand societies and secretaries, president and secretaries, supporting me, and that Surekha. Because it is, Surekha, you are really doing wonderful job. I have seen you. I did not know you before that you have come here, but since I have been in your touch, I'm seeing that you are really doing a wonderful job, and you are good at it. So, and my regards to Dr. Professor Kalyani, who is the President Saharsa and also guest of honor with me. There are a lot of people. Lakshmi, very well, I know Lakshmi since very beginning. For long is a story when we met, but this is not the time to share. And that, as I said, that Bihar and Jharkhand is very close to me. Dr. Vinita, Dr. Bharat, Dr. Ranjana Joshi, and gave me a lot of suggestions while I was going for the election in 2021 for president. Thank you so much, Mitra, for this. Dr. Leela Vyas, Dr. Pratibha Rai, Dr. Maya Shankar Thakur, Dr. Rekha Jha, Supriya, very good friends, Dr. Kavita Baranwal, Dr. Shweta, Dr. Shashi, Dr. Lata, Dr. Apurva Datta, Dr. Sangeeta Thakur, and Dr. Sadhna Sinha. All of you are doing a great job. These are the small societies, but they are really doing a great job. And the topic you have chosen, feto-maternal surveillance, is a pillar or cornerstone for the India to reduce the maternal mortality and morbidity and neonatal mortality and morbidity, which we are fighting and struggling for so long now. Although we have seen a great change, and I'm sure that in coming time, we are going to see much changes are there. So it's a great topic you have chosen, the inverted pyramid of antenatal care and the CTG, and the case-based discussions on the CTG is a great thing. I'm sure that all delegates are going to learn and really going to learn, because CTG is still a little complex. So we have to make a good judgment, because it has been now almost is being abused that this is going to be the reason for increased rate of cesarean section. So my only request is that we all have come a long way with the CTG, and we have improved so much in saving our neonates and the maternal life also. So please, just by doing a little bit more about the CTG, learning more about the CTG, will really save from the point which we are always are being said that now the OBGYNs are doing a lot of cesarean sections, and this CTG is being like is coming like this. So the interpretation of CTG is very important. It is not like that as soon as you get a CTG, which is not very dramatically bad, So we can wait, we can still give a trial or labor. We should see that patient is not dehydrated, patient is not having any other problem. She's lying, give her left side position, give her a little bit of oxygen, and see what are the factors you can correct, and then repeat the CTG. And little weight is not going to change, I suppose, many things, unless it is very bad and you need within 15 minutes a C-section. So thank you so much, Surekha, for inviting me, and to all the people who are here. I'm really thankful to you. And a great speaker, Dr. Mitra and Dr. Lakshmi is going to do a great job, and you are going to do a great job. I'm sure that if I finish, I may join later.
Yes, ma'am. Thank you so much, ma'am. Thank you very much for all the guidance you have given us. And yes, we are now very happy, very much honored to invite another very great person from Bihar and Jharkhand. And when I have heard about her,
one sec,
from her own.
Just permit me to leave at the moment. Okay, thank you.
Yes, ma'am. Thank you so much.
Join with the same later on.
Yes, ma'am. Same.
Okay. Thank you so much. Thank you so much.
So it is a great honor to invite another very important personality, and really must say a person of great stature, that is Professor Kalyani Singh, ma'am. And when I learned about you and the kind of students you have and the way you have guided youngsters, I thought you remembered my own professors who are of your stature, ma'am. And you are the professor and at Lord Buddha Kashi Medical College, Saharsa, founder, member, and vice chairman at the Lord Buddha Kashi Medical College. More than 14,000 major surgeries, including 5th and 6th cesarean section. So we must, after listening to this, we do know that how much work you have done and since how long you must be working. I think more than 35 to 40 years of madam's span of work, and founder, member, and president of Saharsa, published many papers in national and international journals, and she's the member of editorial board of Journal of Gynecology and Obstetrics of Advancement from UK. So both academics and publishing, research, and as well as the type of work she has done for the community and serve the community. So madam, you are an inspiration for us and we await your guidance. Dr. Kalyani Singh, ma'am, please unmute yourself.
Thanks, Dr. Surekha, for inviting me and for your high words. We and Dr. Sangeeta, we belong to a very remote, distant place of Bihar, and we don't get much opportunities to meet people from the other parts of the India. So this is a great opportunity that you have invited us, and we could meet you and Dr. Mandakini and Dr. Yashoda Pradeep, Dr. M.G. Hiranar, and you have chosen a very good topic. Fetomaternal surveillance and the CTG. This is a very important, as Dr. Sudha told, this has been a major reason of increased cesarean section, CTG. So perfect interpretation of the CTG is very important. And so I thank you and congratulate you for such a good topic and for such a successful webinar.
Thank you very much, madam. I think Dr. Surekha madam's connection is
Can you hear me? Is there any problem?
Yes, we have heard you, Dr. Kalyani.
Yes, she will
hear me, madam.
Yes, we could hear you. And okay. On behalf of Dr. Surekha, I, Dr. Mitra Sikana, welcome you heartily, because it is so nice that such an experienced senior is here in our program. And really, Surekha has done a tremendous job to bring everybody on board. We are getting to meet, look at you people. Let's hope that we can meet in person also. Thank you very much, Dr. Kalyani. Rashmi, please take the academics further.
Yes, ma'am.
Thank you very much, Professor Kalyani, and we are really honored by your words And I would request now Dr. Rashmi to take ahead the sessions. Thank you, ma'am.
Thank you very much, respected dignitaries. Let us move towards our academic session. And the first session is inverting the pyramid of antenatal care. The speaker for this session is none other than Dr. Lakshmi Shikhande. I would like to introduce the respected chairpersons for this session. Dr. Vinita Singh, madam. Can we have the slide? Madam is Associate Professor, Department of OBGY and NMCH Patna and Consultant Care Hospital and IVF Center. At present, Dr. Vinita Singh, madam, is President at Patna Obstetrics and Gynae Society, and she is also FOXI ICOG Governing Council member, Young Talent Promotion Committee Chairperson, FOXI 2017-19. She has been Joint Secretary, Clinical Secretary, Treasurer, Vice President, Executive Committee member of Patna OBGY Society, and a member of Safe Motherhood and Quiz Committee and Practical Obstetrics Committee. Madam has been Organizing Secretary NYCOA in 2019, and she also was an invited faculty in workshop Figorio 2018. She is a recipient of M.G. Mishra Award in 2004 and George Mane Award in 2012. It's an honor to welcome you, ma'am, to this session.
Thank you, Dr. Rashmi. Thank you for a nice word.
Dr. Bharat Prasad, sir. Sir is ex-visiting professor, CIMS Bharatpur, Nepal, and has been former professor at Darbhanga Medical College, Darbhanga. And Santosh Medical College, Ghaziabad, and Saraswati Institute of Medical Sciences, Kapur. Sir is founder secretary and present president of Darbhanga Obstetrics and Gynecological Society and has been actively involved in organizing 5th annual conference of AOG BSG 2012. He has also served as the vice president AOG SBJ. Welcome, sir. Our next chairperson for this session is Madam Dr. Ranjana Joshi. Madam is HOD of Department, Tata Children's Hospital, Jamshedpur, and she is at present President Jamshedpur Obstetrics and Gynecological Society. And she has many publications in AICOG and journals, and her special areas of interest include gynae-oncology, iris pregnancy, and robotic surgeries. We welcome you, ma'am. I would like to hand over the session to respected chairpersons for the session. Thank you very much. Next slide, please.
So thank you very much, Dr. Rashmi, for your kind introduction. At the very outset, I would like to thank Dr. Surekha Tade for giving me opportunity in such a wonderful CME program, which has been organized and including all Bihar and Jharkhand societies. It's my pleasure and honor to introduce Dr. Lakshmi Shikhande, a very towering personality in the horizon of FOXI, and she is known for her academic acumen, and she always mesmerizes me when she gives her talk. So for a formal introduction, she is at present Chairperson-elect ICOG Indian College of Obs and Gynae, National Corresponding Editor, Journal of Obs and Gynae of India, Jogi, National Corresponding Secretary, Association of Medical Women. She is founder, patron, and president of ISOPARB Vidarbha Chapter 2019. She is chairperson, IMS Education Committee 2021 and 2023. She is president, Association of Medical Women, Nagpur AMWN 2012 to 2022. Nagpur Ratan Award, Hands of Union Minister by Hands of Union Minister Shri Nitinji. Received Bharat Excellence Award for Women's Health, received Meru Hansotia Best Committee Award for a Chairperson HIV/AIDS Committee, FOXI in 2007 to 2009, received appreciation letter from Maharashtra government for work in the field of Save the Girl Child, Senior Vice President FOXI 2012, President Menopause Society Nagpur 2016 to 2018, President Nagpur Obs and Gynae Society 2005 to 2006. She delivered 11 orations and 450 guest lectures and publication 30 national and 11 international publications to her credit. And she sensitized 2 lakh boys and girls on adolescent health issue. So we can see how much appreciated CV of Dr. Lakshmi Shikhande is. Now we all know that inverted the pyramid of antenatal care because there is lots of changes in antenatal care. Now we are coming with preconceptional care, antenatal care, and the entire pyramid has been inverted. So over to Dr. Lakshmi Shikhande to talk on inverting the pyramid of antenatal care.
Yeah, thank you. Thank you so much, Dr. Vinita, for your such a kind and warm introduction. And Surekha, I must say that you are doing a fantastic, fabulous work. I know Surekha since last, I think, Surekha, 20 years when you
Yes,
were in
ma'am.
Sevagram and now you are in Sawangi. And I know what a fine academician and orator you are. And I wish you all the very best for your election campaign. And for this webinar, you have given me the topic of inverted pyramid of antenatal care. So friends, first let us know why at all we want to do antenatal surveillance. What is our purpose? That is, we want to triage mothers to high risk and low risk. We want to screen the fetus for chromosomal errors, structural defects, growth abnormalities. We want to predict and prevent wherever possible the maternal complications, and we want to decide the time and mode of safe delivery. So what used to be our traditional care, or rather still many of us are doing this traditional care, where pregnancy management typically involves reacting to the maternal and fetal problems only after they develop. So they develop problems and we treat those problems. Why? Because most fetal and maternal complications, they become apparent late in pregnancy. It has been traditionally thought that it is the most intensive surveillance is required in the third trimester. This is the traditional care. But what we are talking is the Nicolette's concept of inverting the pyramid of antenatal care. So you can see the traditional pyramid and now that is the inverted pyramid. And why we are talking of this inverted pyramid? Because some very important complications that occur late in pregnancy can be predicted in the first trimester itself. Inverted pyramid helps us in dividing cases into high risk and low risk in the first trimester itself. But don't you want to have a basement and a penthouse to this inverted pyramid? And this concept has been brought forth by Khalid and Moore, where the basement is where you are focusing on preconception care, and the penthouse is where you are taking care of this woman after 6 weeks of delivery also. So this is a paradigm shift in the evolution of medicine, and that is the Barker's hypothesis. So what is this Barker's therapy? Barker's theory? This hypothesis proposed that adverse nutrition in early life, including prenatally as measured by birth weight, increases their susceptibility to the metabolic syndrome, which includes obesity, diabetes, insulin insensitivity, hypertension, hypolipidemia, and other complications in the form of coronary heart disease and stroke. So here we gynecologists are concerned with preconception care and its relevance before we proceed to the antenatal care. So why preconception counseling? Because when you are pregnant, you are also pregnant with grandchild. Why I am saying so? Because the eggs that may someday become the grandchild are developed inside the daughter while she is still in the womb within the mother. The eggs are nourished by the diet and environment of the mother. So this is the importance of preconception counseling. What do I mean by preconception counseling? It is a very broad term that refers to the process of identifying social, behavioral, environmental, and biomedical risk to a woman's fertility and pregnancy outcome, and then reducing this risk through education, counseling, and appropriate intervention. This in itself is a very broad subject, but I would like to just give you some points which every obstetrician should look after in the preconception period. And now many of our couples, they are aware of the importance of preconception counseling, and we infertility specialists, we do get a chance to see these couples in the preconception period. So the BMI, BP, lifestyle counseling, Garbh Sanskar ritual, folic acid supplementation, anemia, test for sugar, thyroid, endocrine factors, and we are from Vidarbha where sickling and thalassemia is very common. So wherever indicated, we have to include this screening as well in the preconception period. And don't forget to ask about the vaccination in the preconception period. Foxy recommends vaccination counseling as a part of pre-pregnancy counseling. History of occurrence of vaccine preventable diseases, previous vaccination administered, and allergic reactions to vaccination must be recorded. Rubella, hepatitis B, and varicella vaccination should be given preferably during post-menstrual period, and pregnancy should be deferred for 3 months in case of rubella vaccination. So now let us come to the first trimester from preconception counseling. So what should be advised and what you all should look for? Just look at this case. This is a 26-year-old trimee. She is just overdue by 10 days. This is a natural conception first antenatal visit. So according to the inverted pyramid concept, how will you proceed for her? So first and foremost, of course, you will confirm the pregnancy. You will do the USG for fetal well-being. Don't forget to record BMI, routine blood test, maternal blood pressure, but along with that, mean arterial blood pressure should be recorded. Here I have given you the recommended test and the preferred test. Don't forget to do the blood group and RS typing for both husband and wife. Now let us see step by step what you all can do in the first trimester. First and foremost, I am focusing on the screening for fetal aneuploidy. We all know that fetal aneuploidy is a major cause of perinatal morbidity and mortality as well as long-term disabilities. All diagnostic prenatal tests they use to diagnose fetal aneuploidy, they carry a risk of miscarriage, and these tests are expensive. Therefore, starting with a screening test that is the highest possible detection rate and lowest false positive rate is of critical importance. So until the advent of cfDNA technology, first trimester combined screening, that is maternal age and history, gestational age, anti-measurement, PAPA-A, and free beta HCG performed at 11 to 13 weeks of gestation was arguably the most robust screening test for fetal aneuploidy. But combined test can identify more than 90% of fetuses with trisomy 21. The detection rate for trisomy 18 and 13 is about 95% for the same. But the effectiveness of the first trimester combined screen can be further augmented by the addition of other fetal markers such as nasal bone evaluation and Doppler evaluation of ductus venosus and blood flow across the tricuspid wall. There is evidence that the effectiveness of first trimester screening could also be even further enhanced by including additional maternal serum markers such as placental growth factor and maternal serum alpha fetoprotein. So this was all about the aneuploidies. Now what about structural defects? Can we identify them in the first trimester itself? Let us see what evidence says. About half of the congenital structural defects can now be diagnosed in the first trimester because of the improvements in ultrasound technology, because of the way we measure the nuchal translucency, and the presence of other ultrasound markers can herald the presence of structural defects, and detailed evaluation of fetal anatomy is becoming widely recognized as an integral part of the first trimester ultrasound. What about the detection of open neural tube defects in first trimester? Once it was recognized that the appearance of anencephaly is different in the first trimester from that in the second trimester, early diagnosis of this defect has become a routine. However, the diagnosis of open bifida still remained a challenge. This situation changed when it was recognized that examination and measurements of structures located in the posterior fossa can provide clues to the presence of open neural tube defects even in the first trimester. So in a prospective multi-center first trimester screening study, including about 15,500 normal fetuses and 11 fetuses with open spina bifida, all the affected cases were being identified or at least suspected by a detailed assessment of the posterior fossa at 11 to 13 weeks of gestation. So now let us come to the detection of congenital cardiac defects in the first trimester itself. We all know the association between CHD and NT measurement is well documented. In a meta-analysis that included 20 studies, the detection rate for major CHD based on NT measurement alone was estimated at 44% for a 5.5% false positive rate. Doppler evaluation of blood flow across the tricuspid wall and ductus venosus further improves the screening for congenital cardiac defects. What about the estimation of gestational age? We all know that we want to have a correct dating of this pregnancy. First trimester crown ramp length definitely represents the most accurate method for establishing the gestational age in the general population, more so if this woman is having irregular menstrual cycle. And this accurate gestational age is very, very critical for us because it influences all our decisions later in the pregnancy. What is the importance of first trimester screening if she is having multiple fetal gestations? The perinatal risk of morbidity and mortality we know is always increased in multiple gestation. However, we all know that the level of risk depends greatly on the chorionicity. And this assessment is best accomplished in the first trimester, as at this time, the ultrasound appearance of a dichorionic diamniotic dividing membrane is vastly different from that of a monochorionic diamniotic membrane. This difference becomes more blurred as pregnancy progresses. Estimation of chorionicity in the first trimester allows you to accurately counsel this couple about the risk of pregnancy. Now, this was all about the aneuploidy structural defects, but can we really predict the maternal fetal complications which are going to occur later in pregnancy? Yes, very much. Discussion regarding first trimester screening often focuses on fetal aneuploidy and structural anomalies. This is a traditional way of caring. However, remember, maternal and fetal complications that are related to abnormal placentation are much more common than both of these problems mentioned above. Most placental architecture, including placental maternal blood circulation, is established by the end of first trimester, and there is no further anatomic modifications are evident after the 4th month of pregnancy. And these two facts serve to support the following two assertions. First, the validity of methods used at the end of the first trimester in screening for placental dysfunction has a sound physiological basis. Second, in order for any treatment to be successful in reducing the risk of complications related to placental dysfunction, it has to be instituted early in pregnancy. The two often interrelated complications of pregnancy that are major causes of maternal fetal morbidity and mortality are preeclampsia and small for gestational age fetuses. A meta-analysis of 9 published studies has shown that the use of low-dose aspirin, that is 75 milligram per day, reduces the risk of preeclampsia only if treatment is initiated before 16 weeks of gestation. And this finding has been again confirmed in a more recent meta-analysis. First trimester screening for these complications can be increased by using additional markers. One is the estimation of downstream resistance by measuring the pulsatility index in the uterine arteries. Second is maternal blood pressure measurement in the late first trimester. And third is evaluation of certain placental products in the maternal serum, such as PAPA-A and PIGF. Fetal Medicine Foundation algorithm suggests that detection of early pregnancy, early preeclampsia would be approximately 90% based only on history, maternal blood pressure measurement, and uterine artery PI. The addition of PAPA-A and PIGF level will increase this detection rate to 96% in the first trimester itself. What about SGA? It has also shown some promise. The risk is increased with an increase in the uterine PI and maternal mean arterial pressure. Decreased maternal serum PAPA, free beta HCG, PIGF, placental protein 13, and A disintegrin and metalloproteinase 12 also increase the risk of SGA. For a false positive rate of 10%, the combination of these markers along with maternal characteristics could identify approximately 75% of SGA fetuses delivering before 37 weeks of gestation and 45% of those fetuses that will deliver at term. What about the prediction of preterm delivery in the first trimester itself? The fact that risk of spontaneous preterm delivery is associated with cervical shortening is well established in the second trimester, and the same seems to hold and apply in the first trimester also. Cervical length measurement obtained transvaginally and adhering to strict guidelines in combination with maternal characteristics is likely to be used in the future to select a high-risk group that may benefit from close follow-up and possible treatment. Preterm delivery prediction does not seem to be improved by the use of either maternal serum biochemistries or uterine artery PI. Can we predict GDM in the first trimester itself according to this inverted pyramid concept? Yes, the first trimester screening of GDM is possible using maternal serum biochemistries. Adiponectin and sex hormone binding globulin are reduced and visfatin is increased in association with increased risk for GDM. Combination of maternal characteristics and biochemical markers can identify about 75% of pregnancies that will develop GDM for a 20% false positive rate. Screening fetal macrosomia or large for gestational age using first trimester parameters has also shown some promise. The risk of LGA increases with increased anti-measurement, increased levels of maternal serum free beta HCG and PAPA-A, and a decreased level of adiponectin. For a 10% false positive rate, the combination of these factors and maternal characteristics can detect approximately 40% of large for gestational age fetuses in the first trimester itself. So I have also explained the things which you all can do in the first trimester, and as you all can see, the combined test plus nasal bone plus tricuspid flow or dectus venosus flow, it increases your detection to the tune of 93 to 96% for a false positive rate of 2.5%. Now in second trimester, there are again the recommended test and the preferred test. Recommended test, I know you all very well versed with it. I will just focus on the quadruple marker, anomaly scan, and cervical length. The asymptomatic singleton pregnancy, the TVS cervical length of less than 25 millimeter in second trimester, we all know that is the criteria, but you screen at 11 to 13 weeks, do a transvaginal ultrasound, measure the cervical length, and then measure again at 22 to 24 weeks. Recent evidence suggests that cervical stitch does not help and progesterone may be the treatment option in these cases with short cervical length. Routine McDonald stitch practice should be individualized. This is the integrated first and second trimester screening. And this gives you 97% of detection rate with a false positive rate of 2.5%. Don't forget vaccination in pregnancy, because vaccination before, during, and after pregnancy helps to protect women from serious infections. It can also help in improving the woman's health in general, and it is an important preventable measure which should be adopted rationally. So this is the vaccination chart. TT 1 dose, Tdap second dose at 24 weeks, influenza vaccine 24 weeks onwards, hepatitis B if she is not immunized, targeted vaccine in cases of travel to endemic areas, and postpartum do counsel her for HPV vaccine. Third trimester, our main focus is the fetal surveillance, and this fetal surveillance is the assessment of fetal well-being in utero before the onset of labor. Early detection of fetus at risk, we all want to know, so that timely management can be done to prevent further deterioration. So these are the various methods of antepartum fetal surveillance. I will not go into detail of any, but these are the indications where you have to do intensive fetal surveillance in third trimester. This is a list of maternal conditions, the fetal conditions, and pregnancy related conditions. But I would definitely like to highlight the importance of kick chart. You all can download the kick chart from the Google. You can give this kick chart to your patients. She has to count 10 movements every day. Should be around, if she has having less than 6 movements in 2 hours, tell her to come to your clinic and she should report decreased fetal movements to you. So these are the FOXY guidelines, FOXY GCPR. It is freely available on our FOXY website, that is foxy.org. So to summarize, according to this inverted pyramid, we have to give maximum attention to the first trimester, that is up to 14 weeks of pregnancy. And what information we all can get is fetal aneuploidies. If you detect, you have time to counsel. Patient can opt for MTP. You can detect structural defects, neural tube defects, cardiac defects. In cases of multiple gestation, you can be sure of chorionicity, and accordingly you can counsel the patients. You know the exact dating of pregnancy. You can predict the preeclampsia and you can start aspirin before 16 weeks of pregnancy. You can predict GDM, fetal growth restrictions, the chances of preterm delivery, and in cases of Rh negative pregnancy, you can predict the fetal anemia. So this is the importance of first trimester screening, that is the inverted pyramid. And again, don't forget the basement, क्योंकि अगर न्यू मजबूत है तो बिल्डिंग मजबूत है, तो don't forget and do counsel and take care in the preconception period also. And once she becomes postpartum, do counsel her if she's having GDM, she's having hypertension, tell her the importance of lifelong surveillance. So we all know a child gives birth to a mother, let it be a pleasant experience for her, and with the knowledge and help of these latest technologies, we can predict any problems in the first trimester itself. We can counsel and we can do timely intervention. Thank you. Thank you so much for your patient hearing.
Thank you very much, madam. That was really wonderful and very elaborate and really important lecture. And with that, I would like to invite the comments of Dr. Vinita Singh and Dr. Anjana Joshi ma'am and Dr. Bharat Prasad.
Indeed, it was a very elaborate talk. And initially, the first trimester is very important. I think also preconceptual area is also, that is also very important. So we have to put more stress on preconceptional period and the first trimester, in which we can assess and we can find so many complications we can treat and we can make, you know, madam ne kaha hai ki neev agar majboot hai to building majboot hoga. That's really true. So it was a very nice talk. Dr. Lakshmi Shikhande, thank you very much.
Ranjana Joshi, ma'am, your comments, ma'am.
Thank you, Dr. Surekha, for this wonderful opportunity and to allow me to be a part of this August platform. Thank you, Dr. Lakshmi, for this fantastic and energetic presentation. Inverted pyramid. Yes, this concept is new, yet it is old, because we have again and again seen such cases where we have regretted if only we had done a thorough first trimester investigation. So I think this after preconceptional counseling, first trimester investigation is the ultimate for all of us gynecologists to ensure that we bring out healthy babies, or rather predict healthy babies. So I think your presentation is so complete that I mean, any other question, I think if someone has, we can ask for. But yes, definitely we have come a long way from having nothing, knowing nothing, to exactly predicting even future fetal-maternal complications later on in pregnancy. Thank you, Dr. Lakshmi, for this superb presentation.
Thank you.
Thank you, Dr. Ranjana. Thank you, Dr. Vinita. And really, it's an honor to have such great personalities as chairpersons and the speaker here. Again, so elaborate. And do we have Dr. Bharat Prasad, sir? Sir ji, aap hai? I had talked with sir. He said he's going to join. Probably he'll join later. So with that, I would really like to thank our chairpersons for today and speaker for their wonderful comments and opinion, and that the participants are really benefited by this. Thank you very much.
Thank you, Surekha. Thank you.
Thank you, ma'am.
Thank you.
And thank you, Dr. Anjana and Dr. Vinita. Thank you so much. And with that, I hand over to Rashmi.
Thank you very much, Dr. Surekha, madam. Now let us move towards our session 2. And the session 2 talk is basics of by none other than respected Dr. Mitra Saxena, madam. I would like to introduce the respected chairpersons for this session to the House. The first chairperson for basics of CTG talk is Dr. Leela Vyas, madam. Can I have the slide, please? Slide change, please, Nisha. As we all know, respected Dr. Leela Vyas, madam, has been Vice President FOXI 2018. She is a former senior professor and unit head, IVF consultant, member of Research Review Board, SMS Medical College, Jaipur, and senior consultant, Kupal Hospital, Jaipur, and senior consultant, Aesthetic and Cosmetic Gynecology at Vyas Clinic, Jaipur. Madam has been chairperson ISA Rajasthan 2020-21 and president NARCHI Rajasthan 2016 and 17 and president Jaipur Obstetrics and Gynae Society 2013 to 2015. It's an honor to welcome you, madam, to this session. Our next chairperson is Dr. Pratibha Rai, madam. Madam is Professor and HOD, Obstetrics and Gynae Department, PMCH Dhanbad, and Medical of MCIX. She has been at present, she's President of OBGY Society Dhanbad, and she has been Organizing Secretary of 4th AOG SBJ Conference. She is a guest speaker on safe abortion at Kathmandu, Thailand, and member of FOXI, ISAR, IME, Dhanbad. Madam has presented various papers and publications in national journals. Her special areas of interest include infertility, high-risk pregnancy, and genital malignancy. We welcome you, ma'am. Our next chairperson for this session is respected Dr. Maya Shankar Thakur, sir. Sir is a practicing OBGYN and is at present Secretary of Darbhanga OBGY Society. We welcome you, sir. With this introduction, I would like to hand over the session to our respected chairperson for introduction of Dr. Mitra Saxena, madam.
Leela Vyas, ma'am, please. You're on mute.
Good evening, everyone, and thank you very much for organizers. The task you have given me to introduce Dr. Mitra, we all know that how she is working in FOXI, how she is active, and it's she's I think a friend for everyone. And Mitra used to call me Leela Didi, so I always taken her as my younger sister. And on her, these all work which she has been doing for the last 2 years that we all have seen that practical obstetrics means the practical obstetrics, which is, it is associated with us in day and day out with this, our profession. So it's a very means branch, which means committee of that is of a use of everyone, and everyone, we can't say practically, if you'll ask me that whether I'm an expert in obstetrics everywhere, but sometimes some hurdles I'm also facing for either because of some infrastructure or some other points, or I would not like say everyone is not of a knowledgeable, but even the things are not in your hand and you are not able to tackle these patients. So always be very proactive to learn everything. So every time all these webinars becomes very important to learn and to refresh your knowledge. And always I praise all the juniors, those who are doing hard work in during this COVID period, especially all these webinars. Now we are physically also meeting, but still I think as the cases are coming on, we have to continue with this. So regarding the Mitra, she is senior consultant OBGY at the Rewari, Haryana, and she is one of the renowned obstetrician there. She is past president of Rewari Society, and she is convener for the project director of Mukti, and she is means very active member of that society. She is very good orator. I have heard in that. I have seen her working. So in obstetrics is in her blood, I will say, because her mother, ma'am, is so senior person, and I know that she has learned everything from ma'am also. And so Mitra, the stage is yours. And again for this, I think your tenure is 2 years more. So we will enjoy your working and to enjoy with you. And this regarding the CTG, as previous experts has told that where we put the CTG. CTG, we all know that's a CTG. Yes, sometimes it increases the rates of cesarean, but it saves us also. And where the patients getting sonography in, if you are living in some remote area and the sonography once done, IUGR patient, the finally way that when to deliver that, this the option we have only, that is the CTG. So there is a long controversy on that, but I'm not coming in between the Mitra and you. So you just, we want to listen, Mitra, regarding the
Thank
CTG.
you, Leela Di. Dhanyawad.
Tell all the best. So
we are honored, madam.
I'm not able to share the screen. Why?
Please allow share screen to Mitra ma'am. आप phone से तो नहीं ना join हुए, computer से?
नहीं भैया. I can't take you lightly.
Host, please allow share screen.
Sharing is allowed.
Okay, ma'am. Okay, Di.
So
yes.
After the initial question of am I audible and visible, I bring you greetings from Rewari up north in Haryana. And as this, the name of this talk has been coined by dearest Surekha only, ABC of CTG. So well, I'll have to skip a few very basic slides, which I think all of us are well aware what CTG implies. Continuous monitoring electronic of the fetal heart along with the uterine contractions. And there are two probes, one to pick up the fetal heart and the other to pick up the tone of the uterus. Although the tachograph is not so accurate, yet it is quite informative, and now the machines in market are very, very standardized. Now, what is the common difficulties in understanding CTG? Firstly, it is to identify the graph. When we read the theory, we find it's very easy. But when we are looking at it, when a patient is subjected to CTG, are we able to interpret that graph in the perspective of that pregnancy and that labor which that baby is going to go through? And what our aim is to be able to correlate the fetal oxygenation with the reserve and what will be the response of this baby to the stress of labor. So basically, friends, Even after knowing, reading, learning so much, still we are unsure, lost, puzzled, confused. But I am sure with this brief overview, talk on CTG, and where I'll try and explain, and of course follow through with the cases, we'll all be much better placed in understanding different types of graphs in labor. So we all know that why we need fetal monitoring, because with the regular uterine contractions, every fetus is going to be subjected to transient interruption in the oxygenation at the time of uterine systole. A baby, a fetus which has got ample oxygenation will not suffer, but that fetus which is already compromised, the time of uterine systole will be sufficient to cause a stress on the baby's compensatory mechanisms. And now also, immediately nothing happens. Things keep on deteriorating over a period of time. So if we are vigilant in understanding what is the status of the fetus at the outset, during labors, during progress, what's happening, we will be able to predict that what will happen in the second stage. Because all of us know that it is the second stage of labor which we are always afraid of. So we have to understand by looking at the CTG, which is a healthy fetus, what are the points in a graph which give us very reassuring information, and what are the things which show to us that this is a fetus needs to be carefully monitored, because we are not finding the reassuring pattern. So we all know all these definitions of acceleration, deceleration, but in my talk, I'm going to be taking it more in a more detailed way, so that, just one second. Komal, I'll give you a call after half an hour. I'm in a, I'm giving a talk, please. Huh? Okay. So the aim of understanding CTG for intrapartum surveillance is simply that we are able to, triage which baby is fine and is going to be fine and which baby is not. And anything can happen during the course of second stage also. So our aim is to reduce unnecessary interventions and panic, and also not sit on something which is ominous. So we have to tread a very, very careful, path. The whole story is of the fetal heart. Dil ka mamla hai. So what we have to understand is that the baby's heart, it only responds by decreasing or increasing. A well-oxygenated fetus where the autonomic nervous system, the parasympathetic and the sympathetic are in good balance, the baby's heart is going to be showing variability, accelerations with movements, etc. But whenever there is a compromise, the baby's myocardium, so that the injury to the myocardium is reduced, the fetal heart slows down. Now, this algorithm is very, very simplified. Whenever there is hypoxic stress, there's deceleration. So the fetal heart rate is slowed down. So myocardium, the rate of contraction decreases. That is, there is deceleration. Also, baby conserves energy, so the fetal movements are decreased. This is a compensatory, adaptation. But release of catecholamines. Suppose a baby has had a fetal heart rate which was on the downside, and later you find that there is a fetal heart is rising. Let us not feel confident. We should understand that the fetus is trying to compensate, and now the catecholamines have come into play. That is why the heart rate has increased. So these changes which are happening in the fetus during a course of labor, if we understand everything, what is the physiological, pathological basis of the changes, we'll be able to understand and pick up a baby which is compensating or decompensating. So apart from the changes which are going to happen due to some pathological things, there are other reasons also which can affect our CTG finding. So if the mother's posture, we know that if the mother is in the dorsal position, there is venocompression, and that itself can cause hypotension in the mother, and that can reflect into the CTG changes. Similarly, if the mother's temperature is high, there'll be changes in the CTG or fluctuations in blood pressure. Again, at the fetoplacental level, if the gestational age is lower, the heart rate is on the higher side. Post-mature babies or mature term babies, heart rate is on the lower side. We have to understand that in physiological and pathological conditions, there will be changes in the CTG. We are going to come at the changes due to placental insufficiency or cord compression in next few slides. Similarly, depending upon the baby's movements, behavioral state, whether the baby is sleeping or awake, or if there is hypoxia, there will be changes in the CTG. Also, some CTG changes could be due to exogenous factors. For example, if there is noise, the baby is going to have startle, or if the mother is sedated or sleeping, or she's a smoker, or she's on drugs. These are all factors which can influence the graphs of the CTG. Now, very quickly, I will try to recount that during deep sleep, we have stable baseline. We may not have any accelerations and the variability may not be too much. Yet, this need not be confused as a ominous sign, because we have to wait. We have to understand that the baby after another 50 or 60 minutes will be showing some movements, and this CTG needs to be repeated if we are getting no accelerations and borderline variability. During sleep, if there is active sleep, rapid eye movement, that time we already, because the baby is moving, and there will be moderate number of accelerations and normal variability. However, it is the wakefulness time when we are going to get maximum number of accelerations and good variability. So these are some of the things we have to understand which can influence the final interpretation. Now, briefly understanding how do we get the baseline variability? See, baseline variability means that the autonomic nervous system is in agreement. So the sympathetic always increases the heart rate, parasympathetic slows down, and this shuttling between slight increase and slight decrease is what contributes to the baseline variability. So one has to understand first how to identify the baseline variability and then to interpret it. So if we don't have baseline variability, we should know that there is something wrong. But when the autonomic nervous, somebody is, Surekha, can you ask people to mute? So whenever there is hypoxia,
please mute everybody else.
Whenever there is hypoxia or there is some problem, then the variability, the loss of variability, I am stressing that even if there are no accelerations, but if there is variability, we can be reassured that this baby's autonomic nervous system, sympathetic and parasympathetic, are interacting and they are responsive. So this is a good sign. Now, parasympathetic, the vagus nerve, that is responsible for the slowing down of the heart. So all the activities in rest are carried out by parasympathetic nervous system, and the fight and flight responses are by the sympathetic nervous system. So a fetus cannot increase oxygenation to myocardium by increasing the rate and depth of respiration that occurs in us, because it is already floating in an environment of amniotic fluid. So how does the fetus respond to, when the demand increases, its heart rate slows down, so that, the baby is not put under more oxygen requirement. So the slowing of heart is basically a compensatory mechanism which is carried out through the parasympathetic nervous system. So we all know that the stretch receptors and the chemoreceptors, all innervated by the parasympathetic nervous system, are going to be responding to the physiological and pathological stresses. So the baroreceptors are stretch receptors. They respond to the compression of the umbilical cord, whereas the chemoreceptors, they come into play when during uterine systole, there is hypoxia, increase in H ions and carbon dioxide accumulation, and they take longer to get stimulated, the chemoreceptors, and through chemoreceptors, the heart rate will come down. So whenever we talk of decelerations, we have already, gone through early deceleration and late deceleration. So this is just to recount that the early deceleration is a baroreceptor mediated stretch response. So whenever umbilical cord is compressed or the scalp is, pressure, so then that causes the stretch receptor mediated deceleration, and this is basically going to rectify. This is not omnious, and typically the duration of deceleration will be less than 60 minutes, 60 seconds a minute. Now keep it take time to recover because this is all a chemical change. Once the pH comes back normal after the fresh oxygenation in uterine diastole, that's the time that the deceleration will come back to normal. So there is a lag at the time due to metabolic acidosis. So that is why if a heart is showing late deceleration, we have to be, very vigilant. These are graphs showing you early deceleration, wherein the dip in the heart rate is corresponding to the peak of the contraction. And in the late deceleration, the dip, arises after the peak of the contraction is already there. So when there is contraction already there and there is hypoxia, rise in H ions, that is going to, through chemoreceptors, cause bradycardia. So the deceleration starts to appear after the height of contraction, and the contractions comes down when there is relaxation, fresh oxygenation, and the heart rate recovers. Now what we have to realize is this beat to beat variability, if it's still there, like it's here, so this deceleration means nothing because there is good recovery, maintenance of baseline and variability. Here again with deceleration, there is beat to beat variability, which is a reassuring change. Now, variable deceleration, we have to understand, is when the dip in the heart rate is not in relation to the contraction. So not every contraction there will be deceleration, and this is, in between contractions, just because whenever the umbilical cord is being compressed, so we see the variable decelerations. Now, variable decelerations, they are the commonest types of decelerations, and numerous ways they have been defined. Because, whenever umbilical cord loop is compressed, sometimes due to postural change, mother takes, turns by the side, or we make the patient turn by side, and the loop is, put off from the pressure, and it becomes all right. Now, in variable deceleration, we have to identify those which are uncomplicated and those which are atypical and complicated. So we have to understand the concept of shouldering. Whenever umbilical cord is compressed, the first thing will be umbilical vein will be compressed, and with further increase in pressure, the umbilical artery will be compressed. So now, if we go back, the first part where there is a rise in the heart rate at the onset of variable deceleration, and in the recovery phase also again, there is a height. So these two are the shoulders of this deceleration. If this shouldering is there, we have to understand that this is not omnious. But if there is no shouldering, then that is an atypical and more omnious kind of variable deceleration. Again, the duration is very important. If the drop is less than 60 beats and less than 60 seconds, it is typical or uncomplicated. But if the duration is more, means for a longer time, if there is stress, if there is deceleration for a longer time with loss of shouldering, then obviously we have to understand that this baby is going to get decompensated. So also, as I said, that if there is loss of variability within the deceleration, we have to understand that this is becoming pathological and it is signifying coexisting uteroplacental insufficiency. Mechanical compression of cord doesn't imply that there will be fetal hypoxia, but there is slow recovery, atypical deceleration. It means that if labor is going to take longer, baby is going to be more hypoxic. So variable deceleration, as I've already said, they vary in shape, form, and timing in relation to the uterine contractions. So That is how we have to understand that within variable deceleration, we have uncomplicated decelerations, and then we have those which imply that there is something sinister going to happen. Now, our goal is just to identify these fetuses which are at the risk of intrauterine hypoxia, and we have to prevent stillbirths and neurological damage. We have seen that continuous CTG, in fact, increases the intervention. But if we understand it and use it judiciously, we will be better off in taking, healthy pregnancies by vaginal delivery or interrupting earlier whenever we see some ominous sign. So what are the abnormalities in CTG? We all know that there will be a baseline of the heart rate. So there is bradycardia or tachycardia. There are accelerations which are reassuring, which is because whenever there is movement of the baby, the physical movement of the baby, there is increase in the heart rate, which shows that this is a reactive heart. Reduction in variability and decelerations, which become deeper, wider, and slower to correct. Now, let me take you through this very basic mnemonic, Dr. C. Bravado. I'm sure all of you must be very conversant with it, but it is very important to always revise, because CTG is never, just looked at the graph. You have to look at the patient also. So this woman, if she has prematurity or post-maturity, or she has some vessel insufficiency, growth retardation, diabetic or Rh negative, whatever. So we have, the first thing is to define the risk in the mother. Second is, no CTG. So many people I've seen, they'll be just taking the graph of the baby's heart, but not bothering about the uterine contractions. So without uterine contractions, the graph of the fetal heart actually doesn't hold much value. It is the contractions which are going to cause the hypoxia, which is going to create some change in the heart rate, that we have to always see whether we are picking up the contractions properly or not. Now, BRA stands for baseline rate. All of us are aware, less than 110 is brady, more than 160 is tachycardia. The variability, which I have tried to explain to the best of my ability, is very, very important sign. And the normal accepted beat-to-beat variability is 5 to 25 beats per minute. Less than 5 is, we have to review it again. More than 25, again, it has its own connotations. Acceleration, more than 15 beats per minute, lasting for 15 seconds or so, is very, very reassuring. There is no contradiction about that. As far as decelerations are concerned, try to explain the genesis of early, late, and variable deceleration. And the last is overall assessment, which will obviously include the stage of labor, the cervical dilatation, the station, and everything. So now when we are reporting the CTG, what are the things we have to...
25 minutes are over.
Okay, I think I will in another, give me 5-10 minutes, please.
It's 5 minutes more, ma'am. 5 minutes
Okay,
more.
okay. So these are everything that we have to do when we are reporting the CTG. After having looked at everything, we should be able to classify the trace, whether it is normal, suspicious, or pathological, and what will be the clinical management. Important thing to remember about CTG is that it is a thermal paper which needs to be photocopied so that the graph doesn't disappear if we are planning to use it for documentation. And always, the CTG machine should be, once it is started, the details of the patient, the timing, everything should be written. Surekha, let me take, this is very important. So this is the CTG graph where the particulars of the patient, date and time. This is very, very important. Otherwise, without date and time, CTG graph doesn't actually help at all. And see, this is the X axis defines the time, and the Y axis is the amplitude or the beats per minute. That will tell us the heart rate, and here the height of contractions. So it's very important to understand, and a good quality CTG is for at least 20 to 30 minutes, where we should have both the heart and the contractions, toco and the heart. So now we have to also understand that the speed of the paper is 1 centimeter per minute. And what does one small row vertically, what does it mean? This much is 5 beats and the 4 together means 20 beats. So when we look at it, we know that from the baseline, this means 1, 2, 3, 4. So at least 20 beats ka increase hai. So this should be very clear in our mind. What is the strength of one small row and what is that of a whole big one? Similarly, for the time scale, we have to know that one small column is 30 seconds, one big column is for 1 minute, 3 big columns for 3 minutes. So if we see from here 12:30 to 12:40, this means from year to year, this is implying 10 minutes. So that's why we have to know the duration by the x-axis and the heart rate in the vertical axis. So Surekha will be taking us, but this is a very, very reassuring CTG where we have a stable baseline. There are fetal accelerations. There is good beat-to-beat variability. So this is a very nice CTG. Now, whenever we're looking at baseline, if we have an unstable baseline, we have to know that this is not a normal healthy baby. Something could be wrong. How do we identify? We have to, in that 10-minute segment, we have to search for at least one strip, which is of 2 minutes, where we can define that this is the baseline. So these are some technical problems, which I'm sure during the case studies, we'll be taking these graphs. And here is, these are different graphs to show you normal beat-to-beat variability absent. This is increased beat-to-beat variability, which is showing that there is some compromise in the fetal oxygenation. There is evolving hypoxia, so immediate delivery, and this is sinusoidal rhythm where there could be acute fetomaternal hemorrhage. This is NST, good one. A category 1 or a normal CTG is where the baseline is stable, there is accelerations, there is good beat-to-beat variability, and there is no deceleration. So here you are having everything which is being fulfilled. Even if you don't have accelerations, but the beat-to-beat variability is good with contractions, it means this is a good oxygenated baby with good reserve. So as I said, in category 1 normal, these are the components. Now, this is a graph where there are contractions, and with every contraction, there is deceleration and very little beat-to-beat variability. So this is omnious. This is not something which is, this is pathological, because at least one of the following components is present. There is absent variability and recurrent late decelerations. Most importantly is bradycardia and absent variability. It implies that this is a pathological. So this is the same graph which is expanded to, so for you all to see that variability is not there. So this is again a poor, response, and there is deceleration. So then this is, now suspicious means that we need to re-evaluate the CTG after ensuring that intrauterine resuscitation is done. So there is stable heart rate, there is beat-to-beat variability, but there is deceleration. So this is suspicious. Now I'm going to skip these because this is very important, identifying intrapartum hypoxia, and especially acute hypoxia, where we have to rule out placental abruption, cord prolapse, and uterine rupture, especially if there is drop in the fetal heart rate up to 80 beats per minute, lasting for at least 3 minutes. See, normally if you turn the side and the heart rate recovers, we can re-evaluate. But when we see that the heart rate is not recovering, we have to be more active, proactive, do a PV. See, because this is a hypoxic condition where the baby is going to suffer because of the prolonged hypoxia. So we have to diagnose, stop the iatrogenic cause, for example, tachysystole, and do the resuscitative measures and reassure. You all would have heard about 3, 6, 9, 12, which Surekha will be taking in detail. So I'm going to just give it a skip. And so some important mnemonics: beware whenever there is meconium, or cervical dilatation, we have to know. Progress of labor, we have to know. If you are using oxytocin and that is causing hypoxia and deceleration, you have to reevaluate that whether you can get a well-oxygenated baby without the stress of oxytocin, maternal temperature, hyperstimulation, epidural. All these conditions can cause, ominous signs on the CTG. So remember to stop oxytocin, change the position, oxygenate, give IV fluids, improve the blood pressure, and consider tocolysis if it is causing hypoxia. So there are limitations because there is reduced mobility, and the mother who needs to be mobile and more active is tied down to the machine. So there is always a variation in the interpretation, and sometimes some clinical conditions can make interpretation difficult. For example, if there is chorioamnionitis, and for litigation, if you do not have a good documented CTG with all the details as I mentioned, then maybe it would be better not to use it as a proof. So some precautions which I've already mentioned, that the paper speed has to be 1 centimeter per minute and identification data. And whenever there is some problem detected, instead of taking immediate decision, we have to evaluate and repeat the CTG after resuscitative measures and be sure. We should never doubt our obstetric decisions when we are comparing the CTG record and our decisions as an obstetrician. Important take-home messages before I conclude is that always interpret CTG in context of clinical history and findings, and remember what are the most important things is having a reproducible baseline, stable baseline, good variability, accelerations, and whenever there is some deceleration, review it again in the context of the patient's profile, and prolonged deceleration definitely warrants immediate delivery. So finally, with all the knowledge, I think every obstetrician's decision has always to be final. And this was a patient who was doing very well, and then I saw this deceleration which continued but recovered because of the variability. After, finally outcome was that the patient did deliver vaginally normally. And of course, we have to thank God for being on our side. But of course, these equipments and knowledge always helps us in taking the correct decision. And I do hope that this talk of mine has helped you understand the genesis of the changes in the graph and take better care of the pregnancies and the fetuses. Thank you, Surekha.
Thank you, Dr. Mitra. Thank you so much for that wonderful talk, I must say. And starting from pathophysiology to description of everything normal and then, of course, abnormal. So we do have Dr. Pratibha Rai, ma'am, with us. I would request her for her comments. Madam, you're on mute. Unmute yourself, ma'am. Mute पे है मैडम आप जी हाँ ठीक नहीं लाल बटन फिर से दबाइए yes.
Good evening. First of all, I want to express my heartful gratitude for inviting me in this beautiful talk, and special thanks to organizer, and my happiest congratulations to ISOPARB Vidarbha chapter and Deoli, Sawangi of Sangini and association with other society. Yes.
Yes, madam, please go ahead.
And I want to give, or I congratulate Dr. Mitra Saxena for your excellent talk on CTG, because most of the time it is incorrectly interpreted. So it is very important to know the method of monitoring and assessment of fetal well-being if the professional involved are able to interpret the data correctly and have an understanding of underlying physiology of abnormality that occurs. Regular training is must for the correct interpretation of CTG regarding all staff, juniors, seniors, and teachers. So without knowing the correct interpretation, most of the time unnecessary cesarean section can be done. So, Madam, you have very nicely explained each and every steps starting from normal CTG to pathological CTG. Thank you, ma'am.
Thank you.
Leela
Madam,
Joshi, ma'am,
can I
please.
ask one question, madam? Dr.
Yes.
Surekha, will you please allow me?
Yeah. Yes, ma'am.
Madam Mitra, will you please explain me once again what is shouldering? My video is not coming, ma'am, due to some reason. Shouldering.
Okay. Shouldering means जो variable deceleration है. Firstly, we have to understand what is variable deceleration. Variable deceleration is because the umbilical cord is being compressed. So जब भी compression होती है during uterine contraction, uterus is contracting over the umbilical cord, which may be in between some fetal part and the uterine wall. So सबसे पहले compression होती है तो umbilical vein, being the thin part, it compresses. वो compress होती है, थोड़ा सा blood pressure rise होता है, जिसकी वजह से heart rate increase हो जाती है. उसके बाद जब umbilical artery भी compress हो जाती है with increasing contraction, तो heart rate depress हो जाएगी, deceleration होगी because of the stretch receptors being stimulated, and you know stretch receptors are through vagus and they cause slowing of the heart rate. So to protect the myocardium so that the oxygen requirement decreases, heart rate slow हो जाती है. It is so simple. तो वो जो decelerate होती है तो वो dip करता है. This is because the umbilical artery is also with increasing pressure. पहले umbilical vein compress हुई, so slight increase in blood pressure and increase in the heart rate. And then once the compression is continuing because of the uterine contraction, the umbilical artery gets compressed and the full stretch receptors, they stimulate and the heart rate comes down because there is hypoxia, kind of temporary cessation of the blood supply. So how will the heart respond? By slowing down. So it goes down. Now when it is recovering, so the heart rate will come up and it overshoots because once the pressure goes away, the umbilical loop is no more under pressure. There is no hypoxia, so it overshoots. So both at the starting and at the end of the deceleration, these slight going up above the baseline is called shouldering, and that is an additional, change.
Dr. Maya Shankar Thakur sir is there. Sir, please, your comments, please. Yeah, I think sir may not be able to hear us. Shouldering is actually when it goes down and then it goes up.
Shouldering means, Surekha,
that is
before and after the
way of
shouldering means before the just at the start of the variable deceleration is going to go up, and then the
up,
deceleration
then
comes down,
and
again it goes up and then comes to the baseline. So दोनों तरफ shoulders होते हैं. That's it.
जी ma'am. Thank you.
Hello, Dr. Surekha.
One of the talks where which can be recorded and heard again and again. Yes, ma'am. Sangeeta Thakur, ma'am.
Hello. Sorry, Dr. Surekha. मुझे एक इमरजेंसी पीपीएच हो गया, उसी पेशेंट को डिलीवरी हुआ, फिर मैनेज करने जा रहे हो. ओके
जी मैम, कोई बात नहीं. Thank you, ma'am. Thank you. And we move ahead to the panel. Rashmi.
Dr. Surekha madam, Dr. Vyas madam is there, her opinion.
Yeah. Vyas ma'am, please, your comments. Leela ma'am, you would like to say something?
No, you all have discussed. There is a shortage of time. Now you discuss all cases.
Right,
because there is an endless discussion on this CTG.
Yes, thank you so much.
Discussion.
Thank you, Rashmi.
Thank you very much. Thank you.
Rashmi, please go ahead with the panel.
Now let us.
Mitra ma'am, if you have time, please stay back for the panel.
I'll close my video, but I'll be there.
Right. Rashmi, please go ahead.
From traces to cases. This is the interesting title of our very interesting panel discussion on CTG based cases. So my moderator for this panel discussion is Dr. Surekha Tade. As we all know, Dr. Surekha Tade is professor and unit in charge, JNMC Sawangi Vidarbha. She's a teacher, trainer, guide, mentor, with a very great aptitude for clinical research and a very deep involvement in women welfare community projects. Can we have a slide projecting Dr. Surekha Tade? Nisha.
You can skip mine, Rashmi. Go ahead.
The experts for today's panel discussion are Dr. Rekha Jha Madam and Dr. Supriya Jaiswal Madam. It's an
Please
honor
move ahead, Nisha.
To welcome Dr. Rekha Jha Madam. Madam is at present is President Bhagalpur Obstetrics Gynecological Society, and she's an active member of Public Awareness Committee of FOXY. She's a member of Rotary Club, consultant gynecologist, and she's also Chairman Diabetes Society Lions Club of Silk City and Vice President IME Bhagalpur 2021. We welcome you, ma'am. Our next expert for the panel discussion is a dear friend of ours, Dr. Supriya Jaiswal Madam. Madam is at present Secretary Patna OBGY Society and Chief Consultant, SM Hospital Patna. She's specialist at Government Hospital, Communicator Central ISOPARB, East Zone Coordinator, Adolescent Health Committee of FOXY, and member of Adolescent Health Committee FOXY. Welcome, Dr. Supriya Madam. I would like to introduce our panelists today, Dr. Kavita Banwal. Madam is Senior Consultant and Laparoscopic Surgeon, Samarpan Hospital, Munger, and recipient of Padma Bhushan Kamalabai Hospital Award. She is a member of Young Talent Promotion Committee of FOXY 2021 and 22. Welcome, Dr. Kavita, Madam. Dr. Shweta Kumari, Madam. Madam is Consultant Obstetrician and Gynecologist and a private practitioner. She is Senior Consultant Medical. She has been Senior Consultant Medical Super Hospital, Jamshedpur, and at present Secretary of Jamshedpur Obstetrics and Gynecological Society. We welcome you, dear Dr. Shweta Madam. Dr. Shashi Kiran Madam. Madam is ex-Senior Junagadh Medical College, Gujarat, and ex-SR Junagadh Medical College, Gujarat, and Specialist Medical Officer at Katihar. We welcome you, Dr. Shashi Madam. Dr. Sadhna Sinha Madam. Madam at present is Secretary of Muzaffarpur OBGY Society, and she is also Secretary of ISOPARB Muzaffarpur. She has been past General Monks, and at present she is Consultant Apollo Maternity Jila Parishad Muzaffarpur. We welcome you, Dr. Sadhna Madam. Dr. Sangeeta Thakur Madam, respected Madam is Secretary at Saharsa OBGY Society. We welcome you, Madam. Dr. Lata Gupta, Madam is Consultant at Lata Nursing Home, Sitamarhi. She is a Founder Secretary of the Sitamarhi Obstetrics and Gynecological Society. She is a member of ISOPARB and IMA and ICRS. She is also President of Lions Club 2002 and 3, and she has a very interest and work in. Next slide, please. Dr. Apurva Kumar Datta, he is the National Coordinator for FOX's CME workshop for Safe Abortion Contraceptive Care, CAFE 2020, and also National Coordinator Public Awareness for FOX's Sexual Medical Committee. He is a regional faculty and master trainer at various organizations and executive founder member of Jharkhand State Chapter of International Bifida Foundation, Spina Bifida Foundation. He is a winner of R.D. Pandit Research Award 2021 and champion of FOXY Award 2021 and a winner of Kamini Rao Yuva Orator 2020. We welcome you, Dr. Apurva.
Thank you, Dr. Rashmi. That was really wonderful. And I must say that all of the panelists and especially, I think, the experts have been interacting with since so many months. And Dr. Rekha Jha, especially, I have been in connection with last 6, 7, 8 months, and so many of the panelists have been interacting in the case-based learning group, especially Dr. Lata Gupta. I must mention Dr. Kavita Banwal. I must mention our friend Dr. Supriya Jaiswal, Apurva Datta, and so many friends I have made with all of you. I feel really blessed, and I must say that in today's session, I also have Dr. Ritu Singh, who is at AIMS Patna. Ritu, can you open your video, Ritu? She is my student, and presently she's student from MGIMS Sevagram, and presently she is in Patna, and she is doing very, very well. I must introduce all of you to Dr. Ritu Singh, who is my dear student, and she has stood first in the university under my guidance, and she has bagged the gold medal from Mahatma Gandhi Institute of Medical Sciences from Nasik University. And I'm really proud of you, Dr. Ritu. She's really working very well in AIMS Patna. And my other student is Dr. Suman Kumar. He is also working in Bihar very nicely in the rural area. And both of these students are very, very dear to me. So with that, I think I will now go ahead. Ritu, you want to say something? No, I'm not able to hear you. ऋतु, आपको आपका ऑडियो ठीक करना पड़ेगा, फिर पैनल हो जाए तो उसके बाद आप बोलिएगा जरूर. ठीक है, so we go ahead with the panel, and first of all I must say that this panel is a case-based discussion, and this panel I'm going to pose the questions, and we have our very learned experts with us, Dr. Rekha Jha and Dr. Supriya, who will be commenting. And we do have, but only thing what I want to request to the panel is we have 14 cases. So let us be brief and let us give the good take-home messages to our participants, and let us, give those crisp messages, the practical tips for all of our participants. So this is my medical college, Jawaharlal Nehru Medical College, and as you can see, a very nice virtual simulation lab is there where we teach and train not only doctors but all the peripheral workers also. So myself, I'm Dr. Surekha Taide, a teacher trainer since 20 years with an interest in research, and I present before you my candidature for Clinical Research Committee of FOXI. The elections are in 2 days' time, the voting will start. These are my esteemed panelists, and my experts are Dr. Rekha Jha and Dr. Supriya Eswar. So this has already been explained very well by Dr. Mitra that CTG is a very important tool. See, on one hand, we are talking of reducing birth asphyxia, and other hand, we are talking of rising cesarean sections, and thus interpretation is what we are now going to look into. We have also, these all have been talked about very well, so I'm not going to actually go into it. Only thing I want to reiterate is Dr. C. Bravado. Dr. DR is defined risk, C is contractions, PR is baseline rate, V variability, A accelerations, D decelerations, and O overall. And by far, we have to look into all the overall what the patient is and how to manage. The interpretation is so very important. So I'm going to skip all this and go directly to our case. First case is for none other than Dr. Kavita Banwal, who is the secretary of Bhagalpur OBGY Society. And Dr. Kavita, can you please read the CTG trace for our participants, please?
Yeah, thank you, Dr. Surekha, for giving me opportunity to participate as a panelist in this important webinar. So this case, this CTG shows fetal tachycardia. So what is CTG? Electronic fetal monitoring that is done by applying two probes, one for fetal heart rate, another for uterine contractions. And most common acronym that is used is Dr. C. Bravado, that has been well explained. Defined risk, Dr. DRE defined risk, and we have to assess the risk whether maternal, fetal-placental, or fetal only. And if the risk is high, then our threshold for interpretation may be low. So here there is fetal tachycardia. So first of all, the normal fetal heart rate is 110 to baseline fetal heart rate is 110 to 160 beats per minute. If it is tachycardia, then we have to see the causes of tachycardia. So this patient is second gravida.
Just let me tell you the case, madam, so that you can explain everything very nicely. So this is a 28-year-old. She's a second gravida. She had a previous one vaginal delivery. Now she is 38 weeks of gestation. She came to us with fever since 2 days. She also has been complaining of decreased fetal movements. So now, as you have rightly said, the CTG is having tachycardia. The variability is good, and there are accelerations also. So what do you think how you should go about with this case, ma'am?
Yeah, at first we have to see the causes of tachycardia. Fever is one of the important cause, so we have to treat fever. Another cause that can be responsible for tachycardia, that is any cause of like fetal hypoxia or chorioamnitis or any fetal or maternal anemia. So first we have to see the causes of fever. Most common cause is urinary tract infection. Other causes can also be there. Recently we have seen many cases of dengue, even corona cases can be there. So we have to rule out the fever. If fever is controlled, and we have to watch CTG again. If fever is controlled, in spite of there is tachycardia, then we can see. Otherwise, we have to rule out. And we also have to see other parameters like contractions. That is measured in Montevideo units. And if there are 2 contractions or 4 contractions in 10 minutes period, and that is less than 200, then we don't think there is any other concern for any dangerous or ominous signs in CTG. We have
Yes,
to
ma'am.
look for the accelerations, decelerations, which has been well explained, and overall assessment. So I think in this case, after knowing the causes of fever and ruling out the fever, we can wait for CTG, and even after that, there is tachycardia or there is another abnormality, then we can think for induction on
Yes,
labor or anything else.
absolutely, madam. You're absolutely right. And madam has really nicely given the take-home messages. The CTG may be having tachycardia, but we don't have to treat the CTG. We have to look at the patient. See, patient is having fevers. Find out what is the cause. Is it malaria? Is it dengue? Is it something else? Is it chorioamnitis? And treat the fever of the patient. You may give analgesics. You may give antibiotics. Find out the cause, treat the cause, and accordingly, you will have to manage the patient. Dr. Rekha Jha, madam, you would like to add something to this, madam? Or is it okay? Madam is there?
It is okay,
Yes,
because she has already listed all the causes that can cause tachycardia, and you have already given the treatment. So
yes, ma'am.
Yeah.
Absolutely. The take-home message is you have to look at the patient as a holistic and not at the only the CTG. We'll have to repeat the CTG in this patient and manage accordingly. So Dr. Shweta, can you read this? I would just like to request the all the panelists to focus on the CTG first.
Yes,
and then the case.
First, I would like to thank you and the organizing team for giving me the opportunity to be the part of this panel. And now in this CTG, we are seeing there is a fetal tachycardia, and it is of severe variety because it is, I think, around more than 180 beats per minute. And also there is no acceleration, and the variability is also reduced. The contractions can be seen. And overall, I can say that this is not reassuring CTG. And
yes, I'll tell you the case, Dr. Shweta.
Yes,
See, this is a patient who now is a third gravida, first vaginal delivery. She's a 28-year-old. She is only a 32-weeker and she is having PROM. She now has fever, but now foul-smelling vaginal discharge is also there in this patient. Temperature is 101 degree. She's having tachycardia, as you have rightly said, and reduced variability. Only a few decelerations are also that, as you have rightly said. So how to go about this case now?
Now, in this case, after I would like to know if there is any other associated medical disorders also. And in the examination, I would look for the anemia, built blood pressure, and febrile. You have already told that she is febrile, her pulse rate, and edema also I would like to look for. And then on per abdominal examination, I would like to rule out IUGR if the superficial fundal height is okay, girth is okay. What is her presentation? Presentation, I think, no, it is not yet. Presentation, I would like to know. And then on per speculum examination, I will look for the vaginal discharge, the color of discharge, and whether it is foul smelling or not. And also a gentle PV assessment to look for the cervical ripening. And it is controversial whether we should do PV or not, but gentle PV I can do just to know the cervical ripening. And then I would like to go for the investigation. Complete blood picture, then urine routine examination, blood culture sensitivity, also ultrasound, Doppler study, and biophysical profile. And
yes,
based
Dr.
on
Rekha, your
the
comments,
report,
please, ma'am.
Yeah.
Based on the investigation report, I would proceed for the management.
Yes, Dr. Rekha, your comments, ma'am.
Most important thing was that it is 32 weeks and foul smelling discharge. So first of all, antibiotics have to be started, and on that line only you should go, because the tachycardia is due to the fever also, and due to the chorioamnionitis, and also because of the prematurity. So first of all, start the conservative treatment, and then you have to go and reassess the CTG.
Definitely, ma'am. Thank you both of you.
Antipyretic.
Yes.
Antipyretic, IV paracetamol infusion, temperature charting.
Yeah, so these are important things. First, and the message is that she's having foul smelling vaginal discharge and temperature. So so now this patient is having probably a chorioamnionitis. We need to do the investigation. We should take the cervical and vaginal swab, send it for culture. First send the swabs, and probably then later you should immediately start a broad spectrum antibiotic, as Dr. Shweta has rightly said. And yes, we can. Now, what about steroids? Dr. Rekha, would you like to give 32 weeker?
Yes,
Yeah.
yes.
So there is no controversy. Actually, people may think that there is a chorioamnionitis, so whether it is spread, the infection is spread. No such thing. Let us not be afraid, and let us give the steroid, because that is very important for 32 weeker, that we should give the steroid for lung maturity. And then depending on if she is in advanced labor, then she is delivering fine. Otherwise, if she is not in advanced labor, then we'll have to take a decision for cesarean section for this patient. We have to be alert during the cesarean section that we do not do something which spreads the infection. However, under broad spectrum antibiotic coverage, we'll have to terminate this pregnancy. Dr. Shashi, what about this CTG trace? Can you read this for us, please? Yes, Dr. Shashi, I saw you. You are there. Can you unmute yourself, please? Is she there? Rashmi? If not, Dr. Rekha, can you just read it for us?
Actually, I cannot see what is the, oh, you have indicated here, it is 170. So
yeah, it is 170 beats per minute.
Yes.
Yes.
Hello.
Yes, yes, Dr. Shashi.
Hello.
Yes, Dr. Shashi, are you there?
There are decelerations also.
Yes, yes.
Most likely it corresponds with the uterine contractions. But
yeah,
variability.
If Dr. Shashi is there, then Dr. Shashi can respond. Otherwise, I would like Dr. Rekha to kindly.
We cannot see
the ma'am, I'm busy in a cesarean section.
No problem, Dr. Shashi. When you come back, we will have your comments. Dr. Rekha will take over.
So there are some decelerations which can be seen. So there are two like concerning features, that the heart rate is 170, and also there are some decelerations, but we cannot see the uterine contractions, whether these decelerations are in line with
the small CTG, the cardiac tachograph is there visible, but probably there are no contractions only. Yes. Otherwise, without contractions also there are decelerations, and the variability is poor, as you can rightly said, and the
two non-assuring factors are there. So
yeah, I'll tell you the case, ma'am. I'll tell you the case.
Yes.
She is a 6th gravida. She had 4 abortions. She's a 36-year-old. 1 vaginal delivery. She came to you at 37 weeks of gestation, the APLA syndrome positive, and she is on low molecular weight heparin. Now she took this 40 milligram of low molecular weight heparin at 9 a.m. And when she came to you, this is the very suspicious type of CTG. As you can see here, you rightly said that there are patterns which are of concern. And she came to you at 7 p.m. and she had pain since 2 p.m. Now, what do you think? This is the admission CTG. How to go about it in this patient?
I think in this patient, since she has taken at 9 a.m., labor should be expedited.
Yeah, definitely
cesarean section should be done.
The cesarean section is needed for this patient because, as you have rightly said, there's loss of variability, there's deceleration. There are no contractions till the decelerations are there, and the poor variability showing that there is some problem in this patient. Now, only concern is about this low molecular weight heparin. What to do about if you want to take cesarean section? Is this of concern?
Already she has taken at 9 a.m. and quite a lot of time has passed. So as far as I think, it can be done after 10 to 12 hours.
Yes, ma'am. We are very, very right. There may be a risk of bleeding, which you can be alert about. You can plan for the blood and blood transfusion. Fresh frozen plasma can be kept in hand. But however, I think there is no need to be afraid. And you can very well do a cesarean section if it can be done in 10 to 12 hours of the low molecular weight heparin. So very rightly said and very good take-home messages from Madam.
There
here.
was tachycardia
So
also,
sort of,
Sureka.
yeah, there is a tachycardia,
Yes,
170 per
tachycardia.
minute.
Yes, it was 170.
Loss of variability, tachycardia, and
Yeah,
deceleration.
Ominous sort of pattern is there. So this is called as a gradually evolving hypoxia, where we have this kind of pattern, and this is where you have to take the patient for cesarean section, as rightly said. These are the traces which warranty that you have to terminate. One is a deceleration without baseline variability, baseline tachycardia without deceleration, prolonged deceleration, and a sinusoidal pattern. So this is for Dr. Sadhna Sinha, ma'am. Can you read this trace for us, please?
Yes, madam.
Yeah,
madam, I cannot see actually the heart rate is between. I
yeah,
cannot see
the heart rate initially is quite normal, madam. It's almost like 140 beats per minute.
And the latest is showing decelerations and again acceleration. This shows there's some hypoxia in the fetus. Maybe oxytocin is given. If the patient is on oxytocin, it may cause hypoxia, and then if she is on oxytocin, it should be stopped. And again, we should wait and watch for the recording. If it improves, then there's no need to worry. If this graph doesn't change even after removing this oxytocin, then we have to find out the cause for the hypoxia.
Right,
And,
right, ma'am. Supriya, you would like to say something about this? Dr. Supriya is there?
Dr. Supriya has left, I think. I have.
Okay, okay. Then Dr. Rekha, I would like your opinion, please, ma'am.
It has been rightly said that we have to see the overall picture, whether oxytocin is being given or not. As in between, we can see the accelerations. Though it is not a very clear graph, but yes, 1 or 2 or 3 accelerations are being seen. And the heart rate, which was initially, you said it is around 120 or 140?
140.
140. Yes. That after these decelerations, it is going a bit down. And even the irregular uterine contractions can be seen. So most probably it is due to that oxytocin.
Yes. Dr. Mitra, please, you want to comment this patient? What we should do?
Actually,
so
obviously,
this patient,
there is a kind of step ladder pattern. It's declining. The heart rate is coming down. And as I sorry, miss, but this is with oxytocin. The first and foremost thing is to switch off this oxytocin and hydrate the patient so that the uterus is relaxed, and we evaluate the heart rate, whether it comes back or not. And of course, we have to rule out any other reason for sudden acceleration.
So you're talking of oxytocin, you're talking of cord prolapse, it could be an abruption. So any acute event,
hemorrhage,
acute hypoxia has to be ruled out.
Acute event to be ruled out. If you stop the oxytocin and everything becomes fine, then you may you may continue her labor. You have to evaluate the cervix. If it is 8-9 centimeter dilated and she's delivering,
expedite the delivery.
Yeah, and expedite the delivery. That is very nicely the take-home messages were there for this patient. So let us remember these 3, 6, 9, 12 rule. 3 minutes, you have to call your team, summon some help. 6 minutes, try to diagnose what is the cause. 9 minutes, do all the resuscitative measures. And if everything doesn't become fine, then you have to deliver the baby. So now this case 5 is for Dr. Sangeeta. She's not there here. So again, I would request Dr. Rekha to have a look at it.
It is 100, 120, 40. So,
yeah, this is 130.
Yes. 100 and it is going around 150.
Yeah.
The baseline. And there are some accelerations initially, later on also, but the variability is less.
Yes, madam. Definitely.
And later on, there is a deceleration. And again, the variability is almost lost.
So I'll tell you the cause, madam. The patient was 30 weeker. She was an IVF pregnancy. She had severe preeclampsia. She was given magnesium sulfate. Do you think it is because of this?
Yes,
and
because of MAC self, there will be loss of variability because of MAC self. Yeah.
Yeah, so definitely when you have such kind of pattern, the first thing to do is to find out what is happening, what drugs has been given. Is it because of magnesium sulfate? Sometimes it may be just because of the steroids also. So instead of taking the decision just on the small strip of, whatever we are seeing 5 minutes, you have to take a longer strip probably after you, it may be just because of the magnesium sulfate. You cannot just treat the only the trace and take decision just because of the trace, but find out what are other problems. And she being a severe preeclampsia, we have to go ahead and manage the case according to that. Or you need to probably this is a drug effect. You wait for the lung maturity, you evaluate the patient. What about the labs? Her LFT, her KFT, how the BP is going about, and then depending on the whole evaluation, you need to take the call on the patient whether you want to terminate or not. This CTG, this one CTG cannot tell the decision. You have to repeat the CTG and again evaluate the patient completely. Dr. Lata, can you just read this CTG for us? Lata ma'am is there, I saw her. Yeah, you can just unmute yourself, Dr. Lata. Yeah.
Thank you, Dr. Surekha, for inviting me and making me a part of this panel discussion. Here, this CTG is showing the baseline heart rate is 150, and you are not seeing any accelerations. Almost there are no variability. Small variable decelerations are seen. This mainly indicates hypoxia.
Yeah, so this patient actually was a 24-year-old primi gravida. She was 36 weeks of gestation. She came with tense abdomen. Her blood pressure was high, 140/100, and this is her CTG. As rightly said, this is hypoxia. What can be the cause, Dr. Lata?
Yeah, whenever a patient comes with a tense abdomen and with a raised blood pressure, we always think first which comes to mind is abruptio. So it is a case of abruptio placenta, and she needs delivery. We have to do immediate delivery of the baby. We have to assess the cervix, see if it is favorable, we can give her a normal delivery, and if it is unfavorable, I think we have to go for a cesarean section in this case.
Absolutely, madam, you're absolutely on the track. Yes, very rightly said. This is a placental abruption, and this is a hypoxic pattern which we are seeing here. So we investigate the patient, we do the ultrasound, maybe clinical also we can say whether this is abruption or not. We look for the blood group typing, what's her hemoglobin, what's the CBC, what's the coagulation profile. And rightly said, if the cervix is favorable, we can go ahead and we can find out if she is in advanced labor, she's going to deliver, it is fine. Otherwise, she may need the correction of anemia, and you have to address the issue of the placental abruption of this patient. Very, very rightly said, ma'am. So we go ahead now. Dr. Apurva, I have seen you there. Are you there? Please, can you read the CTG for us? Apurva? Yeah, he's there. Can you hear us? Just unmute yourself. Are you traveling? I saw you in the car. If not, Dr. Mitra Saxena, can you just read this for us?
No variability.
I'm always so much afraid.
No.
Okay.
Yeah.
No contractions.
So we can see this one graph. Actually, what is the clinical condition of this patient when you will tell me?
I'll tell you, but you definitely
the heart rate is between 120 140. So
yes,
130, I think.
130.
Am I okay? Is that 140 upper 120? This is 130. This heart rate is quite stable, but the beat to beat variability is almost less than 5. So it's very low.
So she is a 39 weeker. She has gestational diabetes, which is controlled. She's not in labor. She came to you.
There is no acceleration. There is no deceleration.
So she is a gestational diabetes mellitus. She's telling you absent fetal movements, 39 week. What do you say? Should I do a cesarean section immediately?
No, definitely. The heart rate is there. We will evaluate the whole patient. I mean, the obstetrical examination has to be done. Of course, if she is not in, I mean, like already mentioned, she's not in labor, she's controlled. So we would like to basically do the complete obstetric examination and per abdomen, pelvis, everything. And we need to, I would say, after a small period of time, repeat this CTG and see if this is the sleeping time and this loss of beat to beat variability and no acceleration is because the baby is sleeping, then maybe we can get better graph. But yes, definitely if the cervical score is too poor, baby size is good, we are expecting not a very smooth labor, especially if she's not in labor. Of course, it would
What
be
about the
prudent to
blood
do a
sugar,
section.
Dr. Rekha? Do you think it's
You've
important?
written that it is controlled. You've written
No,
it is
it is controlled,
gestation.
but now probably she didn't have
Yeah.
any food or something.
Yeah. So that will
What
be
do you
good. You can do the blood sugar and see if there is hypoglycemia. Or
Yeah. First of all,
baby
I
is
think we
sleeping.
need to admit this patient.
Yeah,
find
definitely.
out, what is
not
her
in the OPD, to admit and then reevaluate after doing complete clinical examination
and
and
this
repeat
is a very
CTG.
short trace. I think we need a longer trace to find
Longer
out what's
trace, yeah.
happening. And probably then we can decide by the cervical. Yeah, Dr. Apurva, this is your case.
Ma'am, I'm extremely sorry.
Yeah, it's
Actually,
fine.
there was a
Everybody
case,
is
and
doing
that's why.
cesarean section in Bihar.
Yeah, no, I'm totally, absolutely free. Yeah.
So your final comments, we did discuss this case and we did come to the conclusion that you need to reevaluate, you need to admit, and you need to then take a call on what you should do for this patient. So Dr. Kavita, this patient, again a googly for you. What do you think? What is this?
Yeah, actually, I don't think this CTG is perfect because only CTG, by seeing only CTG, we can't make any decisions. So I think,
I'll
yeah.
tell you the case.
Yeah,
That is
it should be
absolutely very right way of reading the thing, that I cannot just read, let me know what the case is. Okay, so I agree with you. सिर्फ CTG के कागज से कुछ नहीं होने वाला, मुझे बताइए कि patient क्या है. So patient is a second gravida. She's having a previous vaginal delivery and somebody another hospital told her कि आपको cesarean section करना पड़ेगा. पर उसको विश्वास नहीं हुआ तो वो आपके अस्पताल में आ गई. तो आप अपने कमरे में थे, आपने सिस्टर को बोल दिया कि नर्सिंग स्टाफ को कि आप सीटीजी लगा दीजिए. आप सीटीजी लगा दिया उन्होंने और ये व्हाट्सएप पे भेज दिया आपको. आपको क्या लगता है, ये सही है सीटीजी? कैसा
I don't think
लग रहा है?
I don't think this is perfect. So I will advise that wait for some time and you do repeat CTG, or you can give some IV fluids also, and thereafter we will ask her to repeat CTG and take a proper length. I think the time taken
ये
is
तो ना
also very
सीटीजी
less.
एकदम ही
छोटा सा
100 वाला लग
छोटा
रहा
सा
है.
है
100.
जो कुछ नहीं क्लियर हो रहा है तो पूरा अच्छे से देखेंगे. इवन एग्जामिनेशन ऑफ द पेशेंट शुड बी डन, प्रॉपर एग्जामिनेशन. ओनली सीटीजी रिकॉर्डिंग कैन नॉट मेक एनी डिसीजन. सो आई थिंक पेशेंट का एग्जामिनेशन करना चाहिए, पूरा देखना चाहिए. एंड इफ फैसिलिटी इज देयर वी कैन गो फॉर अल्ट्रासोनोग्राफी आल्सो. ओनली बाय सीइंग दिस सीटीजी वी कांट ऑप्ट फॉर cesarean section. If there are other indications or if there is any non reassuring pattern of CTG or in fact ominous pattern, then we can opt for cesarean section. Otherwise I don't think we will plainly do cesarean section in this CTG.
Actually, Dr. Kavita, मैं आपको बताना चाह रही हूँ कि ये नर्सिंग ने. Yes, Dr. Rekha, you want to add something for this patient?
I could see some bradycardia in this.
Yeah, पर मैं आपको बता दूँ, ये नर्सिंग स्टाफ ने लगाया था. जब जाके देखा खुद ने तो ये शायद मैटरनल
हार्ट रेट को पिकअप कर लिया. या मैटरनल हार्ट रेट को पिकअप
कर दिया गया है. तो ये हमें जरूर मैसेज देना चाहिए कि जब हम कोई सीटीजी निकालते हैं तो सबसे पहले देख लो कि भाई ये फीटल हार्ट है, ये मैटरनल हार्ट है. नहीं तो इस वाले सीटीजी पे हम सिजेरियन सेक्शन कर लेंगे. एक्चुअली ये रियल केस है. जब हमने जाके पेशेंट को देखा तो फीटल हार्ट ही नहीं था. इफ ये सीटीजी पे अगर हम सिजेरियन सेक्शन कर देते हैं तो बहुत बड़ा प्रॉब्लम हो जाता है. तो सबसे बड़ा आई थिंक द मैसेज इज दैट फर्स्ट यू शुड एग्जामिन एंड फाइंड आउट whether this is a really a fetal heart which we are recording, or it is a maternal heart which is getting recorded. So Dr. Kavita, you're really right. This one small CTG cannot tell you anything. Go and examine the
Even
patient.
by stethoscope or Doppler, we can.
पहले देख लो,
yeah, sure.
नर्सिंग स्टाफ इतनी ट्रेंड होती नहीं है कि वो ठीक से आपको बता दे. तो ये व्हाट्सएप वाला वगैरह जो है ना, इससे हम नहीं कर सकते.
अगर if there is absent fetal heart rate, then maternal pulse mostly gets caught, and this type of CTG we really see. So I think इसमें फिर से इसको repeat कराना या खुद से देखना या ultrasonography कराना.
Yeah, Dr. Shweta, can you just read this for us? We'll quickly go with the cases now. Dr. Shweta, please. Shweta is there? I saw Shweta was there.
Yes.
Yeah. Shweta,
can
please,
you hear me?
Yes. Please go ahead.
Okay. This is showing normal fetal heart rate, and also the beat to beat variability is also good, and acceleration is seen. There is no deceleration. So overall, I can say that this is reassuring CTG.
Very correctly said. I'll tell you that this is a patient who is a 41-weeker, previous vaginal delivery. Now, what do you think about it? You know, she has crossed the date. She is 41 weeks, normal CTG.
Then what is her parity is there, gestational age there, age is there, CTG is normal. I would like to know about any associated medical condition, and then I will examine her, assess her general condition, and on per abdominal examination, I would like to know whether what is the presentation, symphysiofundal height, and the presenting part is engaged or not, and what is the presenting part. And based on that, also I would like to do the PV to know if on per speculum exam show can be seen and cervical ripening can be assessed, and based on that, if cervical ripening is there.
So this is a 41 weeker. You would like to find out if there is any additional indication for immediately delivering this patient, or you want to wait for 1 or 2 days. Already
Yes, we can wait in this case. We can wait in this case.
Depending on if there is any other comorbidity, probably she needs induction. Otherwise, with this kind of CTG, you can just sweep stretch the patient properly, and then
one ultrasound
Do
can
the cervical scoring.
Fetal weight and Riker assessment, placental.
I would do the cervical scoring, Bishop scoring. And
she said, Dr. Shweta said,
such good CTG. It is good case for induction, provided her Bishop score is good. But if his Bishop score is poor and head is higher, but she is previous normal delivery, I think it's good. It's a good case.
So Dr. Shashi is not there, I think. So Dr. Rekha, I would like your comments on this.
In this case, the 120, 140, the baseline is around, I think it is around 150.
Yes, 150 baseline.
This 150 baseline, and there are many decelerations, variable decelerations, not corresponding with the peak of the uterine contractions. Rather, it is late deceleration, like in the first one and the second one. And then the third one also, it is not corresponding. And I can see some sharp drop in the heart rate in some of the decelerations.
But the one good thing, I think,
W pattern of
So this was a 39
one good thing is that there are accelerations also in between.
And the variability actually is preserved even in the deceleration.
Yes.
So she's a 39 weeker, she's an active labor. So this kind of CTG, what do you think we should do?
We can 32, we can just wait and for the labor to be expedited. We can do that.
If there is no other factor and this is the kind, so we have to just find out what is the actually the PV, the abdominal examination, the cervical examination, and find out if the patient can deliver.
Yes.
Do the PV. And if she's delivering, it is fine. Otherwise, I think she will need expedition of the labor, as you have rightly said. Yes, so that's correction of whatever you may have to give a left lateral position, you'll have to give an IV fluids, you do a PV examination. If she's in advanced labor, fine, she will deliver. If she's not in advanced labor, then probably you'll have to take a decision for her.
Yes.
Sadhana ma'am, this is a Sadhana ma'am is there? Here is a low risk primary gravida. She is 39 weeks. She came to you at 2 centimeter dilatation. You started her on oxytocin, and you know, this is how the pattern came to be. What do you say about this pattern?
The baseline initially it shows between 140 and 140 or 150.
Yeah, it is written, madam, 145 baseline.
Yes, and later on by 5, so many decelerations are there, and these decelerations, they are not coinciding with the contractions of the peak contraction of the uterus, and so this is most commonly because of the cord compression.
Either
So
that or it may be
there is
the
prolonged
oxytocin
deceleration also. So this can be due to hypoxia, fetal hypoxia also.
So what do you say?
Prolonged deceleration.
Late recovery. There is late recovery.
So again, 3, 6, 9, 12 minutes rule. We have to remember what is the cause of this CTG. Is there some acute event or only because of oxytocin? Is it a cord prolapse? Is there an abruption? What is the cause? If you can find the cause, fine. You can give the resuscitation. If the strays come back to normal, it is fine. Otherwise, you need to discuss, you know, your team has to go through this 3, 6, 9 minute rule, and you'll have to take the decision for this patient. Dr. Sangeeta Thakur, madam has, I think she's there. She can read the CTG for us. I could see her. Sangeeta ma'am?
No.
No, Apurva is there. Sangeeta ma'am is not there. So, Mitra ma'am, do you want to read the CTG for us?
170, loss of variability.
Yes. But now, Mitra ma'am, what do you think?
So there is a baseline is above 160. So there is tachycardia. And this is kind of a pseudo-sinusoidal pattern. There is
this is actually a sinusoidal pattern.
Yeah.
Yeah, this is sinusoidal pattern, I think. Yeah.
And
this
there are contractions. We have to.
This is a 32-weeker. She's having leaking since 72 hours and she's a sinusoidal wave pattern. What do you suggest?
So we have to rule out any complication, you know, like what's the weight, what is the status of antenatal corticosteroids, because this patient, 32 weeks leaking, we have to manage the neonatal side as well. And this is not a very reassuring pattern. The contractions are there. So what's the cervical dilatation? We'll have to know that. And what is it? Kya hai cervical?
Unfavorable Bishop's tha, uska 1.8 kg ka baby tha.
Definitely, this CTG pattern is omnious, so one would be better off after informing the NICU to go for section.
And yes, this patient also, we did a cesarean section. The cord blood pH also was acidemic and Apgar score also was low. Neonate had Klebsiella septicemia actually. And that's why this kind of pattern was seen. So rightly said, all the seniors and all the experts, yes, this patient needed a termination and that too by cesarean section. So Dr. Lata Gupta ma'am, this is you.
Here, you are seeing the baseline heart rate is 135 per minute. And the contractions are of medium intensity. The variability is reduced. You can see some variable decelerations, but it is not that alarming. Because fetal heart rate
These are early decelerations, I think. There are early decelerations because they are mirror image of
the peak and the trough.
I think Dr. Lata is speaking, so let her please. Yes, ma'am.
Fetal heart, though the variability is coming to again normal levels.
Yeah.
To the
so actually,
Dr.
Lata, this is actually picked up. This whole CTG has been picked up from Mitra madam's PPT actually. As you can remember, she showed this for a suspicious pattern. So what do you think if there is this kind of suspicious pattern, how you should go about in any patient?
So here again we have to.
She's a 39-weeker low risk.
Yes, she's having labor pain since 4 hours. No? So here again we have to reassess her, do the per-vaginal examination to know if there is any meconium stain like her or anything, and we can watch her by giving a left lateral position and oxygenation, good her hydration by IV fluids. And again, then we have to repeat CTG to know what is coming to normal or
absolutely. No. Absolutely. So that's absolutely what it should be done. And that is how we should go about it. Because though there are decelerations, it is you have to reassess the patient and you have to repeat the CTG and find out if there is some persistence of these pattern. Otherwise, you know, you just cannot just on this small TCTG take any decision. Of course, it tells you to be alert in this patient. So we come to our last case, which is for Dr. Apurba. And just can you read this for us, Dr. Apurba? You are there. I have seen you.
170. Yeah, ma'am.
क्या लगता है आपको ये किस तरह का CTG है? जी जी जरूर. हाँ जी डॉक्टर अपूर्व.
Ma'am, this tracing is looking like a case of pseudo-sinusoidal pattern.
आपको क्या लगता है pseudo-sinusoidal pattern है? तो क्या करना चाहिए?
Ma'am, pseudo-sinusoidal pattern is usually it is benign. So first, the reassurance of the patient is very, very important, because many a time and mostly what I have seen in my cases, because the patients are coming from very far places and when they are dehydrated, then I have seen that in case of dehydration, the patient may present with this sinusoidal pattern. So we have to reassure them and ask them to have something, either eat or drink something, and again repeat it. That is the main. Bada karke we should for the 20 or 30 minutes. So it usually turn out to be normal.
Yes, definitely, Dr. Apurba. What do you say, Dr. Rekha Jama?
Can I see once again? I was not.
Yeah, I'll just show you, ma'am. This is the CTG.
So the baseline, I think, is around 160 and 180. And yes, sinusoidal, but the recovery period is quite fast. It is not a prolonged recovery.
And the Jagdis pattern, so pseudo-sinusoidal.
Yes. So what he said is correct, that we have to reassess after hydrating the patient and after looking after all the conservative methods. We can then reassess, and for a longer period, we can take out a longer CTG.
Yeah, sometimes it is just mouth sucking. People is putting the finger in the mouth. That may be also giving this, you know, even some analgesia you have given. So all these can also lead to this pseudo-sinusoidal wave pattern, and you have to repeat and longer CTG. And just, you know, this is very small snapshot, so that doesn't take you anything. Okay. So, madam, the final take-home message from your side for all the participants and from Dr. Mitra also. Rekha ma'am, what do you say? Take-home messages.
So, you have already flashed the take-home message that whenever we come across a patient, we have to see the overall patient, how the patient is doing, what is the period of gestation, whether she is in labor or not, whether everything is favorable or not, if we can expedite the delivery, even if the CTG is somewhat not correct, but we can take a longer CTG, and whenever we need help, we should do it within 12 minutes.
Thank you. Yes, ma'am. Dr. Mitra.
Any prolonged recovery more than 3 minutes, then it is really of concern, and it is pathology.
Absolutely, ma'am. Thank you very much. Dr. Mitra, your take-home messages. Brief.
I'm very sorry, but yeah, my first message is thank you, Surekha. You made all of us friends come together, sit, listen nicely to wonderful talks. Everybody's little contribution also helps us. Sometime we don't know when. And so first of all, thank you to
you.
I'm
a good teacher. Everybody has to concentrate.
बहुत अच्छी teacher भी है और तू बड़ी अच्छी coordinator है. you know, I'm getting to see all these lovely people from Jharkhand and Bihar, and they have all helped me so much in my own election. So I'm indebted to all of you. I know so many, इनसे मैंने कितनों से बात की हुई है और आज बड़ा अच्छा लगा. And Surekha was, let me tell you, sorry my message is long. She was telling me कि आप थोड़ी देर रुक जाइएगा. I said नहीं मैं सारा सुनूंगी क्योंकि I mean everybody always adds their own flavor. So
Thank you.
Thing is this, that the more we learn, the more we realize we know less and we need to learn more. So that's my total message, that
the road,
learning never stops. Every time I take the stop, I'll, you know, one concept becomes even more clear. And thank you, Dr. Kalyani, and Dr. One senior doctor also, and Dr.
Dr.
Hiren.
Kalyani, ma'am, your comments, ma'am.
Yeah, thank you.
Please unmute yourself. Madam,
it was a wonderful webinar. I enjoyed it most. और आप सभी लोगों से मिलना बहुत अच्छा लगा. आप लोगों ने बहुत अच्छे ढंग से ऑर्गेनाइज किया, बहुत अच्छे ढंग से चीजों को प्रेजेंट किया, और ये मेरे लिए एक बहुत ही अच्छा एक्सपीरियंस रहा. सारी चीजें सारे लोगों ने बहुत अच्छे से बोला.
Thank you, madam.
आपको डॉक्टर सुरेखा, आपको बहुत बहुत धन्यवाद. और मैं उम्मीद करती हूँ और मैं ईश्वर से प्रार्थना करती हूँ.
It is my pleasure. मैं जरूर आऊंगी मैडम, और मुझे आप सबसे जरूर पर्सनली मिलना है. जरूर आऊंगी.
ओके हम कभी आइए बिहार, जरूर मिलते हैं हम लोग.
जरूर. मेरी स्टूडेंट यहाँ पे है डॉक्टर रितु. वीडियो ऑन करो अपना, और शी'd like to speak something, I think. रितु वीडियो ऑन करो. बहुत दिनों बाद दिख रही हो, बोलो कुछ.
बहुत अच्छा लगा सबसे मिलना.
रितु, she is in AIMS, so I'm very proud of her. Yes, Dr.
Thank you, ma'am.
Such a good teacher. Such a good speaker.
I am without you actually.
अच्छा. कुछ बोलना चाहोगी? हमारी बहुत ही लाडली है डॉक्टर रितु. यस रितु.
मैम, मैं जहाँ पे हूँ आपकी वजह से ही हूँ मैम.
She almost spoke little less, but she did very well in her academics. और मैं बहुत ही, I am very proud that she stood first in the university in her MD exam. So I'm really proud of my student, Dr. Ritu, and we congratulate you, and everybody is really missing you here in Sevagram. So thank you very much, all of you. Dr. Rashmi, for the final votes of thanks from you.
Madam.
Are you there, Dr. Rashmi? Thank you so much, everybody, for being with this wonderful evening.
Yes. Am I audible?
Yes, Dr. Pratibha, please.
Madam, take home message is for all of us that we should not totally dependent on the finding of CTG. CTG is an aid for our diagnosis, but full diagnosis is must. What is the stage of labor? What is the condition? Whether she is suffering from any disease, and whether she is in labor. So just by seeing the CTG, as you have
it alerts us, it is a tool for assessment, but definitely we have to evaluate the patient.
Rule of 369 is very excellent. Thank you, ma'am, for inviting me.
Thank you so much, everybody. Requesting you to
and
kindly
all the
vote
best.
for me.
Yeah, all the best. Thank you. And
for taking such an important topic.
Thank you very much.
Thank you, Apurva. I loved meeting you in AICOG. We had a great fun time. Thank you.
Dr. Surekha, and Dr. Mitra.
Sorry, ma'am.
Rekha ji, boliye.
Yes,
please come to Dhanbad, madam.
Thank you for a very informative webinar. It was very informative, very good, well explained by Dr. Lakshmi and Dr. Mitra Saxena. And really, it was good meeting Dr. Mitra there in the ICOG, but I don't remember if I met Surekha or not.
I came and met you, madam. You were sitting in the first row in the management committee meeting.
फिर कहीं ना कहीं फोटो होगा. I think so.
Yes, ma'am. Yes, जरूर मैम. आप भी थे, कविता दीदी, कविता बनवाल मैम, आप दोनों साथ में बैठे थे.
बिल्कुल. हम लोग
Yes,
थे.
so
I remember.
see you.
Yeah. All the best.
All the best. Vote for me.
Yeah, sure.
All the best, Dr. Surekha.
Sure. You are a teacher, such a good teacher. We will like to. You should join as your person.